pancreaticobiliary system. So what we want to present is the first is application of AI in US. As we know, pancreatic cancer is one of the most fatal cancers. Every year, more than 800,000 pupils die from pancreatic cancer in worldwide every year. Endoscopic ultrasound is one of the most sensitive diagnostic modalities. The incidence of gallstone is about 50%. New cases of cholangiocarcinoma is more than 160,000. US is one of the most sensitive examinations for the diagnosis of biliary disease. In conclusion, US is a powerful tool in pancreaticobiliary disease diagnosis and treatment. However, it has the following disadvantages: steep learning curve, highly operator dependent, the low penetration rate leads to short supply. In recent years, artificial intelligence has made a tremendous breakthrough. Effect of using artificial intelligence to reduce the difficulty of US image recognition is promising. The standard US scanning can be divided into 6 stations for the pancreas and 4 stations for bioduct. By identifying the stations, the endoscope can be localized and operation can be determined. Combining the AI technology and standard station scanning, we developed the BP Master, a deep learning-based US navigation system. BP Master achieved high accuracy in internal, external, and video validation. In the man-machine contest, BP Master was superior than senior endoscopists and was comparable with experts. Here is a video demonstration. So you can see the video. As shown, BP Master can real-time prompt the current stations that has not been scanned, the operation instruction, and annotate the landmarks. It can achieve comprehensive interpretation of the US image and reduce the difficulty of US operation. Now I would like to introduce another application of artificial intelligence of BP Master, that is in ERCP. As we know, gallstones remain a worldwide clinical burden, affecting huge populations. To assist the endoscopists in ERCP, we first applied artificial intelligence to segmentation and measurement of common bioduct and stones, assisting trainees in judgment and learning. Furthermore, we applied artificial intelligence to score the technical difficulty and to make diagnosis assist. The BP Master can real-time calculate the size and number of stones, analyze the key bioduct anatomic characteristics, and automatically generate technical difficulty scores. We conducted a multi-center prospective clinical trial to validate the AI-based technical difficulty scoring. We have enrolled a total of 151 cases with CBD stones from 3 hospitals. The BP master can quickly identify cases with a high risk of failure. There is significantly clinical differences between hard group and easy group identified by BP master. That's all for today's introduction. Thank you very much for your attention.
Hemopill establishes Ovesco's first product line for telemetric diagnostics. Thanks to a quick and easy measurement, it enables the immediate detection of acute bleeding in the esophagus, stomach, and small intestine. The system consists of a small capsule with an optical sensor, the Hemopill Acute, which transmits measured values via radio to the portable Hemopill receiver. It is easy to use and does not require patient preparation, so that the capsule is immediately ready for use, even in an emergency. Since the Hemopill capsule is only about half the volume of conventional video capsules, it is easy to swallow. Using a photometric method, the capsule measures even small quantities of liquid blood or hemetin. The data transmission is secure and takes place in real time, allowing for immediate detection of acute bleeding. In case of gastric bleeding, blood can be detected within a few minutes after swallowing the capsule. A positive result indicates a prompt endoscopy and therapy, whereas a negative finding indicates postponement or avoidance of an emergency endoscopy. The maximum measurement duration is 9 hours. Thus, the upper and middle digestive tract can be examined for blood. Due to quick and easy measurement, the Hemopill Acute can be used in different areas such as endoscopy, emergency room, or intensive care unit. This allows quick prioritization of endoscopic procedures in daily clinical routine. Our therapeutic product range was recently expanded with Lift Up, a thermo-reversible injection solution for endoscopic resection like EMR and ESD. It forms a gel at body temperature, thereby providing a high and long-lasting safety cushion. Lift Up is provided in a kit, together with a matching injection needle and syringes. It is stored in a fridge until use. To facilitate finding the correct layer for injection, the needle is first filled with a saline solution. The flip-off cap of the vial is removed to draw up Lift Up into the syringe. The syringe with Lift Up is then attached to the injection needle. During the injection, the syringe should be held correctly to avoid gel formation in the syringe due to the warming effect of the hands. The injection is carried out until the desired lifting is achieved for a subsequent resection. Innovation at Ovesco is manifold and never stops. Stay tuned for upcoming solutions for your clinical practice and visit us on ovesco.com. Ovesco, innovation in scope.
So thank you very much also to Ovesco, one of our German sponsors. And I think before we learned a lot about submucosal tumor resection, so thank you very much to the Shanghai team and also especially to Maria from Barcelona for her brilliant moderation. The march is going on, the travel is going on. Our next stop is Hyderabad in India. And we welcome Asmaa Al-Kandari from Kuwait City, our moderator for this session. Asmaa, please take over. Hello.
Hello. Hi, Prof. Roche. This is Asmaa Al-Kandari from Kuwait. I'm going to introduce Dr. Nageshwar Reddy, who is currently the chairman of Asian Institute of Gastroenterology and EIG in Hyderabad, India. His contribution in the field of gastroenterology and endoscopy is merely the cherry on top. He received many awards since he started his career, and recently he just received the Crystal Award from ESG. So his contribution is countless. Hi, Dr. Nagy.
Hi, Asmaa, and again, like to thank Thomas Eleni for giving us this opportunity to transmit from AIG Hyderabad. We have 4 interesting cases this afternoon, so without wasting time, we'll start off. Dr. Sandeep, who's our director of endoscopy unit, is going to start the first case. Sandeep, you want to start the case?
Thank you, sir. Can you have the first slide, please? So this is a 68-year-old man with diabetes and obstructive jaundice with significant weight loss for 2 months. His bilirubin at presentation was 44. MRCP showed a hilar stricture, the CHT, with some portal vein thrombosis. PET scan showed a highlighted lesion in the common hepatic duct area and it has mild ascites. We did an ERCP 3 days back on this patient, which showed a stricture. Can I have the next slide, please? So you can see the MRCP on the left panel, on the right shows the ERCP. The stricture is in the common hepatic duct. The confluence is patent. And we took a brush cytology from this stricture, which showed high-grade dysplasia. So the plan for this patient is to do a ERCP with radiofrequency ablation of this hilar stricture and then place a stent, metal stent. I'm using a Pentax scope.
Yeah, Sandeep is using a Pentax side wing scope. Number, Sandeep, that
it's
is
ED34.
34. The feature of this scope is that you have a disposable cap. You can see this here. The disposable cap with a disposable elevator. So the problem of cleaning the cap and the elevator becomes much more easy because you're. So I think this significant.
So can I have the fluoroscopy image? And you have the endoscopy image. So to save time, I passed a Boston sphincterotome. This is a triple lumen sphincterotome with a guide bar inside the bile duct. The small sphincterotomy is already there, and we'll do a cholangiogram to just delineate the stricture. So I inject from top down. Can we inject some contrast, Madhu? Yes, I'll gradually pull back the tip of the sphincterotome down. Keep injecting, keep injecting, keep injecting. Yes, yes. So that's the stricturous area. Picture, please. Inject, keep injecting. Inject some more. Yes. So I just make it a long loop so I get the stricture. So now you can see the stricture better.
Yeah, we can see the stricture.
Yeah, so we have the same image as what we expected to see. And we'll now take out the sphincterotome. And one more thing I would like, can you measure the length of the stricture, please? There are several types of endobiliary RFA available. So this is about 16 millimeters vertical length. So we'll use 18 millimeter length of the RFA probe. And we'll also make one more measurement. Can I have the scope, please? I'll have the sphincterotome at the top of the stricture. You can see that, Asma?
Yeah, I can see that.
So I'm now holding my catheter here. The cameraman can focus here, zoom here. I'll hold my finger here and gradually pull back. This will allow me to know the length from where the upper end of the stent would be to the papilla. So that will help me decide what length of the stent I need to use, because stents can vary from according to the stature of the patient. So here my sphincterotome comes out. So can you have a scale next to it? It's about 8. So just about 8 centimeter vertical length. So if I place my stent, I think 8 centimeters should be okay. It'll just keep out of the papilla. So we'll take it out, exchange to our RFA catheter, the ELRA from Taiwan we'll be using. 18 millimeters length, please.
Are you using the RFA now?
I'm sorry, Asma?
Are you using the RFA now?
Yes, I'm using a endobiliary RFA over this jag wire, which is a long jag wire that we have across.
Can you tell us the setting of the RFA that you are using? Are you using bipolar or soft coag with the RFA? The settings for the RFA?
So we'll be using the generator from Taiwan,
Yeah.
which is a sensitive generator. It has the feedback mechanism. You can set the temperature to a particular, so we will set it from 75 to 85. The moment the temperature reaches this level or it crosses, it stops automatically. Our aim is to keep the RF catheter at the site of stricture, overlapping the stricture. For about 2 minutes, we'll burn at 10 watts. The purpose of RFA is to ablate the tumor locally, which allows the stent to remain patent for longer period of time, and has also been shown to have some benefit in survival of the patient. So not only stent patency, but survival. So that's the catheter which is going inside. It has 4 ring electrodes. You can see that?
Yeah, we can see.
Yeah. So we can also see in the fluoroscopy as we go in, there are 4 ring electrodes, and it's a bipolar catheter. So we don't have to use a grounding pad. I'll place exactly over the stricture. So that looks quite okay.
And how long you're gonna ablate with the RFA? Are you using like 60 seconds or less than 60 seconds?
No, we keep it in one place and ablate. We don't move it around. Once in a right position, it's okay. Can you start now? A little bit. Okay. Yeah. Yeah, start. So we'll attach to a generator. If the cameraman can focus that to the. So this is a very sophisticated generator which measures the resistance as well as the temperature. You start it. So once you press the button, it starts showing the time. This is the time. This is the temperature, and this is the wattage. It's set at 10 watt, and the moment it crosses about 75, it stops. And temperature as it comes down, then it starts off again. Our aim is to burn the area for about 2 minutes, that is 120 seconds. Keep the catheter exactly overlapping the stricture.
Yeah, and Asma, this is actually a multi-bipolar. That is, the multiple catheters. You can see the rings there, and from one ring to another ring, as the current goes and heat is generated. So it's actually a bipolar, but multi-bipolar, so that you can see.
Yeah, that's why I asked about if it's multipolar or just monopolar.
Yeah, no, it's a multi-bipolar. So there are multiple bipolar catheters there. So it goes from one catheter. So it's a bipolar essentially, but it's a multi-bipolar.
And what is the depth of burn that RFA induces? The depth of burn, you just keep it like for, you said 2 minutes. And what's the depth of burn? Till when you stop?
Stop exactly at 2 minutes because it's got an automatic, you can actually look at the generator, the timer, exactly at 2 minutes because you got say 1 minute, 20 seconds now. Exactly at 2 minutes, it automatically stops.
And you see the temperature is at 75, 76. It doesn't.
And how deep the depth of injury?
It's about 2 millimeter depth.
How deep the depth of burn in injury?
So it burns about 2 millimeter depth in the bile duct. So all around it will be about 5 to 6 millimeters as a cylindrical burn.
So it also depends on if you use a higher wattage, you can go up to even 1 centimeter wall depth burn. But usually with this wattage, what we use for 2 minutes, it burns 5 to 6 millimeter of the wall transversely and circumferentially, of course.
Okay, so
yeah, I think it's over now.
So we heard the bell. The reason that we don't use very high wattage and long is that the portal vein is very close to the bile duct and we can cause injury to the, we'll hold it for a minute or half a minute so it cools down. So if we burn longer, it can cause vascular injury and bleeds can occur. So higher strictures are more prone to bleeding, especially if higher temperature is used. Can you? Slowly. Yes. Stent ready? 8 centimeters. Keep it open, please. Yes. I'll use an uncovered stent since it's covering the hilum. It will be 8 centimeter long and 8 millimeter in diameter. So the length of the stent has to be dictated by the height of the patient, because the bile ducts will be very long in some of the European countries, where it's in India, where people are generally short statured. Stricture at the same site may have a smaller length stent required. So here comes on a short wire system.
Do you
The wall
usually combine the stent with the RFA? Or can RFA can be
So there are
single treatment, or
there
you
are
should
several
combine both of them?
now with there are several publications now on RFA and stent using both plastic and metal, but metal makes more sense because then you don't have to remove it. Here goes the stent. You cross the stricture. Still a significant length is there. But these stents will shorten over a period of time to about 30% less. I'm not very worried as long as the lower end is popping out of the papilla and the upper end is above the stricture. Can you open up now? I'll reposition as we come back. Okay. Okay. Yeah. Okay. Please go. Go ahead. Go ahead. It looks quite deep inside compared to the original stricture, but let me tell you, this stent will shorten with passage of time, and the upper end would actually come down much lower down by about 3 to 4 centimeters.
It looks really good.
Thank you, Sandeep, for that excellent demonstration.
Yes.
We'll move on to the next case, and I'm with Dr. Santosh, who's anesthesia, doing the anesthesia for the patient. We already have Mr. Srinivas, who's the technician, and this is the case of for upper esophageal stent and a stent fix. Can we have the first slide with the history? So this was a 71-year-old male patient who had adenocarcinoma distal esophagus. He received CT and chemotherapy and radiotherapy in 29. He is now having progressive dysphagia with vomiting, and a PET CT scored recurrence of the disease in the lower esophagus. You can see the PET picture here showing very intense uptake in the lower esophagus. He has comorbidities like coronary artery disease and so on. The plan is to put a completely covered esophageal stent, but in addition, we know this is not going to stay, so we might have to use a stent fix. So I'm going to use a Pentex EG29 I10 scope. It's a high definition upper GI scope with a 3.2 channel. I think 3.2 channel is advantageous in this case if you want to push some bigger axaries. I'm now going through, and Asma, can you see the picture here, the endoscopy picture?
Yeah, it's clearly.
Yeah. So you can start seeing at about 30 centimeters, then there's some narrowing there. You can see the narrowing with some food material. Okay. So plan now is that I am now this is the tumor area. You can see very nicely there. I'm now going to actually give a contrast injection just above that area because I want to monitor that when I'm putting in the stent. I usually do the stent under fluoroscopic placement, and you can see the catheter now. I'm going to inject some contrast just about site of just above the tumor. Out, needle out. Ms. Srinivas is giving the needle out. Inject and fluoroscopy, please. Inject fluoroscopy. Yeah, you can see on fluoroscopy, I can see the lower end. The lower end is corresponding to the upper part of the tumor, what you injected now. Now, the plan now is that I want to see if I can get this stent through. I can't see an opening there very well, but so what I'll do is I'll use a ball tip catheter with a guide wire, the so-called Hubrisky catheter. I'll use this to try and see if I can pass it through the small lumen that I see, so that I can define the lumen, define what's happening in the lower end of the esophagus. So I go close here, and then I'm trying to see if I don't see very well the tumor, but I'm trying to see if I can pass through. Yes, the catheter has gone through. Can you see the fluoroscopy? The catheter has gone through. Okay. So now, Asma, I have
Yeah,
Yeah.
the catheter
now
passed stenosis.
It's not so tight because the catheter went through easily. Although when you go in endoscopy, it will be tight. So what I'm going to do is, I'm going to now push my catheter a little blindly, endoscope blindly on the catheter, because I know that I can be little more less gentle than normal because the catheter is in place. I'm trying to push my scope through to see, yeah, it's gone through. Can you see it's gone into the stomach now? Which means this, although it looks narrow, but it's elastic narrowing. And this is very important because when I put a stent there, it's not going to stay in place, it's going to fall off. So this stent will not only require placing it properly, but also fixing it in position. So what I'm going to now do is, I'm going to put a guide wire, I'm going to put a stiff jaguar there. And
It's
then,
very nice technique.
yeah, thank you, Asma. So I'll put a jaguar there. And then what I'm going to do is, I'm pull back the endoscope, have my stent ready. So I'm not using through the scope stent, so I have to take the scope out here. And you can see the tumor now there nicely. I'm taking the scope out. It's about, I want to measure the space. It's about 35 to 40. So it's approximately 5 centimeters. So I'll use a 10 centimeters Boston Scientific completely covered wall-flex stent. But
You
important thing is,
completely covered with the
yeah, the reason
How
I'm
about there
using
is
this,
home migration?
yeah, the reason I'm using a completely covered in this case is because the polypoidal area, if you use uncovered stent, it'll grow through. Now, if I use, the other option would be to use a partially covered stent, which would be a good option in this case. But anyway, we are going to use a stent fix to fix the stent. And therefore, even if you use a covered stent, don't make a difference. And this stent is a very good stent, which I've used often. This is the stent that I'm going to use. It's going to go on the guide wire here. And I'm going to, yeah, put it on this. It's, you can see it's fairly flexible. When it opens up, it opens to 25 at the flanks and is 18 millimeter diameter, 10 centimeter in the length. So it should just cross very nicely. I don't want it to be too long to hang in the stomach because that can sometimes produce a problem in the opposite wall. So it's going on the guide wire now. And the technique, of course, is to hold the guide wire with your right hand and to gently use my left hand to push the stent. So I'm stabilizing with my guide wire here. As you can see my right hand, and the stent is being pushed with the left hand. Sometimes there's a little resistance at the throat, but then it goes through. And fluoroscopically, I'm following it now. I know that the lower end is just above the injection that we did. So the stent is gone inside. And can you show me the upper part? Upper part. The upper part is very important. Upper part.
I have a question. What you have done if the scope had not passed or gone through the stricture?
If the scope had not passed, I would have put a guide wire and dilated it. I would put a guide wire. Okay. This is, I think, positioned well now. You can see the markers here. The lower marker is in the stomach. The upper marker is somewhere in the mid part. And you can see the upper marker is above the tumor. The scope hadn't passed through, I would have actually dilated it a little. I don't like to dilate too much. I dilate it only about maximum to 8 millimeters. What I'm going to do after I put a scope, I won't have time to show you this, so I'll show it to now itself. I'm going to use a special device called the stent fix. Now, the stent fix is a device which comes from Ovesco, over the scope. It's just like a over the scope clip. Now, this is a traditional over the scope clip that you see here. This is the traditional over scope clip, right? Now, this stent fix is a modified clip which has got sharp teeth and it's got a longitudinal groove there so that it can go fix into on the stent completely, and I'll show you that. So when you use this clip, it's a full thickness clip which clips the stent to the esophageal wall in a full thickness fashion so that it doesn't migrate. So we are going to demonstrate that, but first I'll just release this stent so that it's in good place.
Do you find it more convenient than the endostitch?
Yeah, it's much easier to use than endostitch. Endostitch, I think there are certain difficulties, technical difficulty. Now I've got 3/4 in now. There's a small part. So I'm going to pull back now so that now I can be Yeah, it's open completely now. You can see that it's open now. The stent is now open. You can see the fluoroscopy stent. I'm going to go in with the endoscope, with the endostitch. Now the endoscope, endostitch, you can see here, and you can see the tip of the endoscope here. You
Yeah,
can
it's
see the
clear.
tip of the endoscope. Yeah, see that now? Where I put in the esophagus fix, yeah, the fixing clip is there, esophagus. Huh? Yeah. So now I'm going to put this in, and then we go down to the edge of the stent, and I'll show you the technique of how this can be used. So this is the edge of the stent that I'm start to see now. Can you see the stent there? Okay.
Yeah, we
The
can see
technique,
the edge of the stent now.
yeah, you can see the stent there. The technique is to, this is the transverse stitch. So I go and see that the scope, the part of the mucosa is here. The most 2/3 is esophagus, 1/3 is the stent. I push it down like this, and then at this point I suck a lot. It's very important to do a good suction here. I'm sucking. More mucosa, less stent, and then I'm sucking now, and then I'm going to release the stents. You can see my hand here. The camera can focus on my hand. I'm sucking, and then what I'm going to do is I'm going to now release the stent. The stent is released. Yeah, the stent is now released, and you can see that the stent, if you have the fluoroscopy picture, also you can see it nicely how the stent is released.
When did you release the stent? There is any like marker or things tell you that you have to release the stent now after good suctioning? Or just you go after good suctioning?
No, after suctioning, you know the mucosa is stuck there. You can see that. It's stuck,
Yeah.
and when I'll show you the fluoroscopy, you can see the fluoroscopy picture much better now. And you can see very nicely how this is how the stent is now there. See that? This is the
Yeah, beautiful. Looks very good.
there.
Amazing.
Yeah. And you can see the fluoroscopy picture. Can you have if you can magnify the fluoroscopy picture and show it, you can see that how it's fixed there. The stent is now fixed with see that nicely. Yeah. Okay. You can see that very well. Okay. Now the plan in this patient
looks nice and easy by your hand, but I don't know how technically will be with others.
I think for you also it'll be easy. You are such an expert endoscopist. So I think this is this technique you can see much easier than the endostitch or all the other devices. This is the device that we've used for long now, and there's a special cutting device which can be used to remove the clip whenever you want. It's a power cutter. We can cut it and then remove, and if you want to remove the stent. Okay. Yeah. So thank you very much. I think we should go to the next case, which Dr. Mohan Ramchandani is demonstrating in the other room. This is another ERCP case.
Thank you.
Good afternoon.
Hi, good afternoon, Dr. May.
Hi, Dr. Asmaa, good afternoon. And we'll straight away go to this case history. He's a 75-year-old male. He's having coronary artery disease. So he's not an operative candidate, but he has presented to us with obstructive jaundice with right upper quadrant pain and significant weight loss since last 1 month. His lab showed that his bilirubin is very high, 28, and he has high alkaline phosphatase. The MRCP has shown hilar stricture, and he has come to us for evaluation of this hilar stricture. And we will be doing ERCP in this patient. For the want of time, I passed the scope down up till to the ampulla and did a sphincterotomy and a pass a wire on the left side. We have yet not obtained a cholangiogram. I tried to inject some air there. Now we'll just go into the left hepatic duct where I could manage to pass a wire, and then we'll do a cholangiogram to see the anatomy here. The MRCP has shown that this is probably type 3 stricture involving left hepatic duct, and but we don't have the tissue diagnosis here. So we'll just do the cholangiogram now. You can see the sphincterotome is now passed into the right hepatic duct, left hepatic duct. So cholangiogram. I want cholangiogram. We did a air cholangiogram. Could you see the air cholangiogram there?
Yeah, I can see the air, yeah.
Yeah, so we try to be minimally invasive, we try to not inject the contrast. We'll do a cholangiogram first, then we'll do brush cytology.
Are you gonna combine the brush cytology with the biopsy or only cytology?
We wanted to do a cholangiogram first, then we'll do a brush cytology because we want to have a because this patient has indeterminate biliary stricture, and there are many definitions now we are using for indeterminate biliary stricture. In fact, we did a randomized control trial where we defined the indeterminate stricture in conventional way. That is, you do ERCP, you do fluoroscopy, and then you take conventional brush cytology or brush biopsy from the biliary tract, and if it is negative on first time, it is known as indeterminate biliary stricture. But now we have many good imaging technologies like MRI, the triphasic CT scans. We can still have a good idea whether this patient has malignancy or not. And in absence of mass or definite evidence of malignancy on cross-sectional imaging, also we are now calling them indeterminate stricture, because the next step in such patient can be cholangioscopy also. But here we are using more conventional imaging. You can see the left hepatic duct is now visualized. So we'll pass a brush cytology. So I'm using this brush, which is known as, can we have that brush, please? This is an infinity brush. And this has got a very special design where we have two types of brush. One is the stiff brush, which can cause defect in that stricture. And then there are soft bristles, which will collect these abraded cells. And then there is a gap also. We'll show you how it looks like once we take this brush.
Now the fluoro in situ hybridization has increased the sensitivity of the brushing, as mentioned here, from 26 to 66% by Kushner et al.
We'll take this brush first, then we'll discuss about that. You can see the brush has come down up there, and there is a radiopaque marker which shows the tip of the catheter, and then there is a nitinol wire and the brush on that top of it, and there is a very good pushability. Can you do the brushing? And you can see how he's taking the brush. So he's doing to and fro motions, at least 5 we do from that stricture side, and we'll show you the design of this brush. So there are the stiff brush are cutting through the tissue, and then there are the soft bristles which catches these the detached cells. Can we have a brush outside also?
Yeah, I think Asma, the question that you asked is that because we are doing rose-like now, our pathologist, Dr. Anuradha, is waiting here for the specimen, and she'll tell us immediately. So that's the reason why we can increase our yield by this rose technique to almost 80%. Otherwise, if we do conventional, as you said rightly, it's only 60%. We can also use a more costly technique of spicholangioscopy, which we found to be useful. And this is a paper that Mohan published in GIE. But I think...
well, I know that for the biliary, we usually combine the FNA with biopsy. And for pancreatics, we go with FNA. It can be enough. But for biliary lesion, we usually combine.
Yes.
But now with these techniques with FISH and MP, we can increase the sensitivity of detecting malignancy.
Yeah. So this brush you can see here, there are 2 types of brush. The stiff brush are gray in color. They are very stiff. And then there is a gap. And then there is a soft bristles. So the soft bristles will collect the cell, and also the gap allows that bristles to accumulate, or the cells to accumulate over there. So now what we will do is we have taken a good sample which our pathologists are examining. We'll
So
try
here I
to.
think they can show this here. If the samples Dr. Anuradha is taken and making both a smear and a smash, both together. We're making two, and she's going to now examine it with a quick staining and let us know in next 3.5 minutes what exactly is the pathology.
So meanwhile, we'll try to pass a wire on the right side because this is a stricture. Now you can see how my technician is helping me out in going to the right side of this biliary system.
Yeah, we can see it on the right side. Looks good.
No, not yet. So we'll try to.
Starting, yeah. So I think we have two choices here, Asma. That is, we can do, as they're trying to pass the wire on the right side, we can either go for two stents simultaneously, one after another, or we can do what is called the Y stent, where you can pass. So one stent in another stent. This will to some extent depend upon the difficulty of getting into the right side. If it is very difficult, you pass a guide wire to the right side, better to go stent side by side. But if it's easy, then you can do a Y stent.
Yeah.
So what you can see that what the assistant is doing, Srinivas is using a Terumo wire, not the standard wire, a Terumo wire, and selectively trying to get it to the right side. There's going to be some difficulty. We'll see what's the difficulty, because the time is only 15 minutes. We'll have to finish this case. We'll see how we can negotiate it through that. And he's using various techniques. Mohan is getting the sphincterotome down there and bending it a little so that it's in the direction. Maybe some injection also sometimes helps contrast to know the exact origin of the right hepatic duct. Are you getting the fluoroscopy pictures well, Asma?
It's there, it's obvious, but now you're injecting.
Yeah. Now we can see the right posterior is actually going and taking off and joining the left duct here. So if you want to go to pure right,
right.
then the right anterior is coming there. But my feeling is that in this case, if you even drain one side, because both the ducts, you can see one of the branches of the right duct and the left duct are meeting together. So what will happen is you're draining more than 50% of the liver here.
Good.
But let them give a little trial, because we're going to get the histopathology meanwhile. That will give us a decision whether we should put in plastic, or if it's indeterminate plastic, if it's a definite malignancy in this patient, a metal stent. So another trick that he's using, Srinivas, is now trying to change to another straight wire, and probably after that a balloon. These are all the various tricks to guide the wire into a specific territory. So he's changed to a straight Terumo wire because sometimes that's helpful. Let's see if that's going to help in this case.
Yeah.
I think, yeah.
Wait.
Yeah, it's somewhere there.
You're now changing the guide wire to straight one, yeah?
Yeah.
Yeah, the guide wire now is sometimes it looks like it's gone into the right, but then again escapes into the left. So one more trial. Yeah, I think.
We'll try from here. Yes.
Yeah, that's where it's separating out. But it goes there, and then from there, yeah, I think, yeah, no. It looked like it was getting into the right, but as you can see, it goes, and then you use.
I think now it's going to the right side.
Yeah, it looks like that, Asma. From here, we felt that, but it goes up to a certain extent and then swings to the left again. I think it's communicating there. The left and right are communicating there, so you can see that's happening. If you can get the right posterior, that will be the ideal. So what he's trying to do is to get the right posterior now, which will then. So he's now doing something which is very important for all the ERCP people to know, that he's switching on to the balloon to guide his guide wire. So Mohan is putting the balloon, and they're going to put a guide wire through the balloon to see if you can selectively get it out there. But my own feeling is that even a single stent would be sufficient in this case. Because the principle,
there is
of course, we know
cholangioscopy here.
Contrast?
Cholangioscopy. The spyglass.
Cholangiogram.
Yeah, we can, but the problem with the contrast, If it escapes out and you can't drain that segment is the problem. So I think they're being very careful with that. We don't want to have a problem of undrained contrast. So I think.
Okay.
So now the wire will have to come out of the balloon before you place it. I think it's better.
You have to chota wire. You have to remove the wire, take out the wire. Go now, go. Go. Okay. So give me wire out.
Yeah.
Wire.
Yeah, now it's come out. So
Yeah.
now you can
Push,
see that
push.
Mohan is going with the wire inside because intubation becomes easier by the wire inside. He's gone deeper now. Let's see if this balloon helps. Okay, balloon is there, right there now. Sometimes you can inflate to straighten the hole.
I'm pulling back to straighten my trajectory. Control.
Yeah, so what is your opinion, Asmaa? My feeling is that both the systems are filling up now, as you can see. Only the right
filling up.
posterior is the only segment we haven't filled. So I think in this case, I would even suggest that we just get a quick check at this, the cytology before we decide now.
अब देखो. No problem. Okay. Okay. Yes. Wait.
The balloon, I think the balloon helped to straighten the.
Yes. Yeah, this one. Yes.
Yes. I think it's open up now.
Yeah.
Yeah, it's going. What you will do if it's the guide wire didn't go there?
Yeah. So we inflated the balloon and pulled the scope. I just pushed the scope down and turned my body right. That changed the direction of wire. And then we got another option of pushing the wire and then it went through. So this is important that not only you change the trajectory of wire by angle tip or a straight wire, but also you can change the trajectory by using sphincterotome, bending it, use other type of accessories like Haber's catheter ramp. There are many ways where you can change the trajectory of the wire. So you can see now there is a stricture over there, and we have separation of right and left hepatic duct. We have yet not seen the right posterior duct.
So I think both the wires are there. And Mohan, we also have the cytology ready. Dr. Anuradha has seen the slides already. She'll just show it to you on the slides. It looks like it's a malignant cells which are very nicely seen. So we'll ask her to project this and show us before you put in the slides.
Okay.
The stents. So Anuradha, can you show us the slides?
We have to dilate this. Okay.
So the plan now is that because it's showing malignant tissue, Mohan is planning to put in 2 stents bilaterally into right and left, so that you can see in this case you can drain more than 70% by this technique. So let's have the cytology shown before we proceed. Yeah, you can see the picture now that Anuradha is there. You can see. Asmaa, can you see the histology, cytology picture?
Now it's clear.
Yeah. The clumps, you can see the clumps of cells there right at around below 12 o'clock position, very nicely seen. There, I think that's a classical clump of malignant. You can see that now. Can you see, Asma?
Yeah, I can see.
Yeah.
I'm just wondering, any special stain like pathologists can use for such a
Yeah,
quick
we'll ask
result?
Anuradha to join us for a second here, and she'll be able to tell us.
Yeah. So these are the brush from the cytology which Dr. Mohan has just given us. As you can see that there is adequate cellularity and there is loss of normal polarity of the cells. And in fact, we can also observe that there are some discohesive cells. If you just go to the higher part, you can see the nuclear atypia. The cells are enlarged and there is a high NC ratio and marked pleomorphism with focal acinar structures. So all these high cytology, high cytological atypia and the increased NC ratio overlapping and single cells favor a neoplastic lesion. So the brush cytology is positive for malignancy and morphology favors adenocarcinoma, probable cholangiocarcinoma.
Thank you. I think that was a very nice histological section that we saw. So, Asma, this is a definite malignancy. So the plan now is to put a Y stent. Mohan is going to put, you can see both the wires. He has shown you the principles. He's going to use a Y stent from Taewong. That's a common company who's got a Y stent. Basically, it has a large LCD openings, and then you can put one stent through another stent. But we're running, yeah. And so after Mohan deploys the first stent, we'll have to go to the next room for the last case because time is running out now. So we'll ask, once Mohan puts in the first stent, we know the principles now, we'll go to the next room.
So the wire in the right side will act as a guide. Will not pass the stent through right wire. It only acts as a guide. So that technique, one has to understand that once you deploy the left stent, you do not have to remove the wire from the left stent.
Okay. Are you gonna use the RFA here or just you're gonna put a stent?
Wow.
The RFA.
In this case, RFA, yeah, we could do, but this case, the problem is, Asma, that we were not sure what it was, and the patient, of course, was not counseled. I think RFA would have been one of the things that we'd have liked to do in this patient, in addition to give better palliation. So you can see now that he has deployed the first stent in the left hepatic ductal system. And the second stent is going to go through the first stent. Yeah. I think we have to shift to the next room where we have Dr. Nageshwar Reddy with the last case, which is a patient with pancreatic lithotripsy.
Well done. It's really good.
Yeah, hello everyone. So we are going to the next final case in another theater. Can I have the history, please? So I will see on the screen, he's a young male, 26-year-old with chronic calcific pancreatitis and type 3 diabetes. Came with pain abdomen, and when we evaluated, found pancreatic large calicles in the head of pancreatic duct with dilated main pancreatic duct. So he underwent pancreatic lithotripsy, as you see on the screen, pre and post. So we'll just take a minute to show how this lithotripsy is being done in our unit. Can I have the video, please? As you see here, actually, I have Dr. Santosh with me, who leads the anesthesia team, and he is doing the epidural anesthesia, which will be done. And this is a Delta 3 Dornier machine, which is used for lithotripsy for both pancreatic and biliary calculi. This is a very high-end machine, which has got utmost safety with minimum shocks being used compared to the earlier versions of Dornier. And as Dr. Vinod is a dedicated person who does this work in our unit. And we usually do this pancreatic lithotripsy, and then depending on the size of the pancreatic duct, we go for a ERCP and to put a stent or not. So now I go straight away into the case. I'm using again.
Also, you can see from the timing of the lithotripsy machine that is actually I've done about half an hour before. So on the same day, lithotripsy and ERCP is done, Asma.
Yeah. And I'm using a Pentax duodenoscope with the Boston Scientific sphincterotome. So I see here, I am just trying to go and get deep into the pancreatic duct to cannulate. Yeah. Okay. Yeah. So please push the wire. As you see here, I'm trying to get into the pancreatic duct because there was this head stone in the head. We pulverized that.
Caliculi are completely gone. Don't see much on fluoroscopy in terms of caliculi. So Rakesh is trying to gently place the sphincterotome towards the pancreatic duct. And whether I don't know, a small amount of injection will help at this stage, Rakesh.
Yeah, just put a little bit of contrast.
So we know where the direction is.
1 second. I just reposition myself. Can just put some water.
Edematous
Water.
papilla there, and that's the reason why the opening is not so obvious here.
Okay.
But once the edema comes down,
Push the wire. Yeah. I'm in. Okay, just position
maybe you
myself.
have to clean the papillary orifice.
Yeah. Can you just put some water and flush it?
So he's going to clean the papillary orifice and
Yeah.
see exactly. You can see the orifice down there. Yeah.
1 second.
Yeah.
I'll just position. So what happens is post CSW, there's a little bit of edema of the tissue.
How nicely placed.
Yeah.
How you're deep in. I think maybe at this time,
can
some
you gently-
injection would help. Some injection would help. Not very powerfully, you have to give it
A
very
little bit of
gently
contrast, please.
so that we'll know the anatomy here.
I just want to ask you here, are you planning to do a selective pancreatic sphincterotomy or?
Yes.
Yeah.
So that
Wire,
the goal in this case
wire.
is to do a deep cannulation with the wire to get into the pancreatic duct, and then after that do a selective pancreatic sphincterotomy, and then put a balloon to sweep out all the remaining fragments. So this is the goal, and you can see one of the issues here, of course, is
Wait.
that the wire is not going very easily
should-
deep
should.
into the pancreatic duct. So Rakesh is sort of manipulating his scope, moving
Yes.
it right and left, and then trying to pass. And now
Yeah.
you can see it's passed through. Can you see that very nicely?
Yeah, I thought that's possible.
Now the wire is passed through and I'm railroading my sphincterotome on.
So the technique he used was he had the assistant fiddle with the wire, while
change
he
the wire,
carefully
change the
did a anti-clockwise, clockwise direction of the endoscope,
Yeah.
so that that wire could find a pathway into the pancreatic duct. This is very nicely shown.
So I was using a thermo wire and I'll exchange that with a stiff wire and then do the contrast injection to delineate the pancreaticogram. And accordingly, I'll do the next steps if it is dilated.
Yeah.
To do
Also,
a
addition can be made on a stent.
Yeah.
In the pancreatic duct, we are now increasingly using the biodegradable stent. If there is a need only for a short time stent, the Archimedes one. But we'll have to see whether there's any need for any stenting in this case, or we can just get away by just. I think Rakesh is
And
now.
how you
where is
decide for the biodegradable stent? The one lasts you have one lasts for weeks, one for days, one
Yeah.
for 1 week. Which
Yeah,
one you
usually, if it's for a prevention or prophylaxis for pancreatitis, we use the one which is only for 4 weeks, the short one. So we have also ultra short one for 10 days. But if it is for longer period, as we want to use it as a stent for the particles to come off or for a stricture, then we use the longer version, minimum 3 months. So that's how we do.
So this
And
looks
how
dilated.
frequent you follow the patient with the fluoroscopy, or like every 3 months you do to see if it's this?
Yeah,
the
no,
stent is still there or-
we would go in, get a plain X-ray done after a month, and again repeat it after 3 months. So we'll know that the stent is dissolved.
Yeah.
If you have a good fluoroscope, if you have a good X-ray, that is good enough. But you can also, of course, do fluoroscopy. So Rakesh, you think some more contrast has to be given?
Yeah,
here?
we just put some contrast and delineate the
So
head
that
and
you
body.
can see Asmaa is huge. In this case,
Screen.
it's about maybe around same as the scope. So it's about 12 millimeters.
fluoro.
12 millimeters. And then there's no stricture that I can see here, obviously.
Yeah.
It's a very dilated duct. So I think this patient probably will require do a good sphincterotomy and a balloon sweep. You can see some thick material coming out already.
Right.
So Rakesh, can you describe the
Yeah.
technique of pancreatic sphincterotomy?
Yeah, so what I have done now is I have put in the stiff wire and then I've with the sphincterotome, I'm going to do the sphincterotomy, pancreatic sphincterotomy, and obviously my cannulotome is at 1 and 3 o'clock position. So what I'm going to do is gently, lift it. Oh, yeah. So now I'll be doing a gentle sphincterotomy. I don't need a large pancreatic sphincterotomy because I just have to push in the stent. But because I am contemplating for a balloon, so I'll do up to the first fold. Yeah, that's enough. Right. I'll just extend the sphincterotomy a little bit more because the more bigger the sphincterotomy is, then the better will be the flushing of the residual fragments. So I'll leave it here and then I'll take out the sphincterotome. I'll introduce a small balloon to flush out the adequately pulverized fragments and then I'll put in a stent. So what I'm going to do now is take out the sphincterotome and then use a balloon to flush out the fragments. Can you give me a balloon?
So one of the things that also maybe dilatation you want to, one of the things that we've been doing, Asma, now in patients with chronic pancreatitis is do this sphincterotomy, not a huge one, but to do like a 5 millimeter like this case, and then use a Titan balloon or one of those hurricane balloons to actually dilate it. Now, the reason why this is important is that unlike a standard pancreatitis or a biliary sphincterotomy, most of these patients with tropical chronic pancreatitis we see here have a small prepapillary stricture. And once we do a balloon dilatation with one of these hurricane or Titan balloons, then what happens is that you can open up not only the sphincter but also the prepapillary stricture.
Yes.
Okay.
So I'm using a Titan balloon from Cook, which is a 6 into 4 centimeter balloon.
So this balloon now dilates the sphincter and also dilates the prepapillary stricture. And once that is done, then you know that any particles that are there, and you can see very nicely that the stone is completely gone here. It's pulverized, and that's the advantage of these modern lithotripsers that we have.
The size
So
of
now I'm using
the size is standard, or you have a bigger balloon?
No, we depending on the size, we can go up to 12 millimeters also. For a pancreatic duct, usually it's 10 millimeters, but you can go up to even 12 millimeters. So this is a dilated duct, so we can go up to 12 millimeters. In this
I'm
case.
wondering, can we do a sphincteroplasty, or we have to do sphincterotomy instead of sphincter?
We don't do plain sphincteroplasty. The reason we don't do plain sphincteroplasty is that with plain sphincteroplasty, you don't get a big enough opening in the pancreatic sphincter. Plus, post sphincterotomy pancreatic sphincteroplasty pancreatitis dangers are there. This is a sphincterotomy followed by a sphincteroplasty.
So
large balloon.
6 mm.
Yeah, you can now see the balloon on the fluoroscopy, now nicely dilated.
So I'll wait for a minute.
The waste is gone.
So this will give you adequate drainage of the fragments, and also there will be a faster decrease in the intraductal hypertension. So this obviously merits a plastic stent, pancreatic duct plastic stent, because that will decrease the intraductal hypertension faster and also helps in giving a pathway for flushing of the fragments.
So there is no stricture as such, Asmaa, in this case. The reason why Rakesh was suggesting maybe a short plastic stent is for the fragments if they want to drain off. But you can also do a balloon sweep also. Rakesh can do a balloon sweep.
Yeah, we'll
do a balloon sweep. In this case, to any of these tiny fragments that are there will come off. Yeah. But you can see this duct is quite dilated.
Yeah.
Almost more than a centimeter, 1 centimeter.
Yeah. So you can see that the material that's coming out, Asmaa, is typical after ESWL. It's not just pure pancreatic juice. It's pancreatic juice mixed with a lot of fibrin type of material, small caliculi. These whitish areas, what you're seeing, are small caliculi.
Now the question here is, shall we just do a balloon sweep and leave it off?
See, I think we can see if balloon sweep is clear, then we can leave it off. So maybe we can do a balloon sweep. So
I think the advantage of the biodegradable stent, you just place it and leave it, and you don't have to go again and take it off.
Yeah, that's it. Yeah. But in this case,
how expensive is the biodegradable stent? Is it expensive?
It's very expensive. It's not by Kuwait standard, but by Indian standards. It's expensive. So the thing also, Asma, is that in this case, I think just a good balloon swim may be sufficient because there's no obvious great
a good
stricture.
sphincterotomy, yeah.
Yeah. So we have been using this biodegradable mainly either for prophylaxis for post-ERCP pancreatitis, and of course, you can see the balloon now inflated. Can you keep?
Yeah.
Now can you come down?
So you can appreciate on the fluoro, the balloon is inflated. I'm slowly coming down, doing a sweep. I don't expect much fragments
you
to
can see
come
all
out.
those material that's coming out now.
Yeah.
Fantastic. You can see the mucus-like material.
Yeah.
So I think that doesn't require anything more now, Asma. In this case,
So we can
everything
just leave
is
it
clear.
on.
We just leave it alone now.
Do you leave
Don't
it?
this warrant. Okay.
But how is the you load? Is it easy to load the biodegradable stent, or is it difficult?
It's easy. It's very easy.
Very easy.
Yeah.
Very nice
So I
demonstration.
think, thank you. We finished the procedures. Again, we just come to our end of our time. It's exactly 1 hour since we started. We demonstrated 4 procedures, 3 ERCPs and 1 esophageal stent with esophageal stent fixation technique. Again, like to thank Thomas and Ellie, and Asma, thank you for moderating this session for us.
Thank you so
we'd
much.
like to
You have
thank
really a
Endoscopy.
great team. Thank you. They
Thank
were
you.
really.
I know
very
you're going to another
excellent.
city, probably in Europe now.
I'm in Milan now. Yeah.
Okay. Thank you.
Just with these days of lockdown, I moved to Milan. It's just a relief. And I hope that all the meeting will come in person. Recently, we're waiting for that.
Yeah. I think we'll definitely meet in person. This is a temporary phenomena. But I think endoscopy on air is the right time now because it came in this period. So all of us had this opportunity. And from all the faculty here at the AAG, Sandeep, Mohan, Rakesh, and Santosh, we'd like to say bye and thank you very much for being with us.
Thank you. Thank you so much. Thank you. Bye.
Imagine a world where every single detail is designed to save lives. With our innovation hubs, we are driving innovation for the future. Our intensive research and development employ the insights from clinicians worldwide through our Black Box Innovation Program. Our latest invention, Discovery, is an innovative device using artificial intelligence to support you by directing your attention to unremarkable potential lesions. Our EUS J10 lineup is designed for optimized procedural efficiency during diagnostic endoscopic ultrasound FNA, FNB, and therapy. And there are further unique innovations. For example, under our Pentax medical hygiene commitment. Like the DEC duodenoscope, its single patient use, sterile disposable elevator cap helps reduce the risk of cross-contamination. And the Plasma Typhoon and Plasma Bag System, a unique solution for fast drying and active storage of endoscopes. By using this system, confidence in the safety of reprocessing outcomes can be greatly increased. For your therapeutic treatments, Pentax Medical develops state-of-the-art devices, such as the multifunctional Splash M knife. It allows clear marking, effective hemostasis, as well as smoother and easier ESD procedures with a single device. Another example is the K-snare, with an adjustable knife on the tip for precise marking and incision, combined with a snare for resection. Or like the Hemostat Wide Cup, that enables fast and efficient hemostasis through its unique bipolar technology, providing less impact on deeper tissue. These are just some of the many smart innovations that make a difference in your daily work, inspired by the Pentax Medical Triple Aim. This is the world of Pentax Medical. Welcome to the world of intelligence.
So thank you to our sponsor Pentax. Nice video, as all the info commercial videos. And what a nice couple, Asma and Nagi. 2 messages. First of all, ERCP seems to be easy. And secondly, you can keep the time, even with 4 cases. So thank you very, very much. We are moving on to an American who is now in Abu Dhabi, Mike Wallace, and he gives us a overview lecture. And to moderate, we connect him with his old home country, and Uzma Siddiqui from Chicago. We had her getting up extremely early. So Uzma, thank you very, very much. I can't see you yet. Can I see Uzma? I think the tech people, they like Abu Dhabi better because the weather is probably better. Hi, Uzma. Nice background. So thanks very much. I hope you had enough espresso, and I hand it over. The next two sessions, it's Mike Wallace, and it's another Mike, Michal Kaminski from Warsaw with a live. Uzma, stage is yours.
Thank you, Thomas. Greetings from Chicago, where it's early in the morning. But I want to thank the Endoscopy on Air team and the course organizers, Drs. Repici and Roche, for including me in this amazing program, and congratulate everyone for this tremendous effort in creating this event. It's my privilege to announce our next speaker, Dr. Michael Wallace. He's the Fred C. Anderson Professor of Medicine at Mayo Clinic, and as most of you know, the editor-in-chief of Gastrointestinal Endoscopy. But more recently, he has taken on the role of chief for the Division of GI and Hepatology at Sheikh Shakbout Medical City in Abu Dhabi. Today, his lecture is entitled Frontiers of Endoscopic Imaging, and it will include some recent endoscopic applications of artificial intelligence technology. Welcome, Mike.
Good, thank you, Uzma. Thank you, Thomas. It's a real pleasure to join everybody on the Endoscopy on Air. This has really become a wonderful format for connecting when we can't connect in person, and I really appreciate the opportunity. The group has asked me to give an overview of endoscopic imaging, something I've been speaking on for more than 20 years now. So I'm going to give a little bit of a historical perspective and then focus on really, I think, what is a transformational change in how we approach imaging technologies and its role in gastrointestinal endoscopy. And we'll leave some time for questions at the end. These are my disclosures. So the fundamental concepts of endoscopic imaging, we have to think about what do we look at when we look through an endoscope. Usually we're trying to find relevant lesions, often that's neoplasia or significant inflammation. And there's three critical issues that we need to address when we talk about imaging. The first is, can we put the lesion on the screen? That means, can we get an endoscope in front of it? And that's not always a trivial task. Some lesions are behind folds. Some lesions are covered by mucus or stool. So we have to expose the lesion first. And AI and other imaging technologies aren't going to help us with that very much. We just have to be good endoscopists to put our scope in front of the lesion. The second issue is, can we see it? So once it's on the screen, do our eyes detect it, and then does our brain recommend appropriate action? This also is not a trivial step. We know that they're very subtle lesions, classically flat dysplasia that's very difficult to see. This is an area where we've seen major advancements in imaging technology. And then lastly, can we classify it? Can we decide what is a benign lesion, what's inflammatory, what's a low-grade neoplasia, high-grade neoplasia, et cetera? Because increasingly that's driving immediate endoscopic therapy. So all three of these tasks fall under the category of fundamental concepts of endoscopic imaging. And we need to remember, when we apply certain technologies, they may apply to only one or two of these, but we will never get away from the fact that we have to be good endoscopists and good physicians to accomplish all three of these tasks. I'm going to jump right to the very end, the concluding statement, just in case your attention wanes at all. But I think the key features or key issues I want to address today are that advances in endoscopic imaging have enabled non-invasive or minimally invasive endoscopic resection and ablation. Fundamentally, if we can see it, we can treat it. And this has been a radical change in the last 20 years, particularly with the management of Barrett's esophagus-associated dysplasia and many early carcinomas where we've transformed from surgical therapy to endoscopic resection. Advanced imaging is closely linked to therapy. And again, the examples, Barrett's and early squamous cell carcinoma, large lateral spreading polyps, and colitis-associated dysplasia are all areas in the last 20 years we've seen a complete transformation from surgical therapy to endoscopic therapy. And that was enabled by imaging. Previously, we couldn't resect these because we couldn't detect them and we couldn't see their boundaries, but now we can, and now we can save patients unnecessary surgery. On the other hand, really the last 2 or 3 decades has seen a stubborn limitation of traditional endoscopic imaging in that they are modestly accurate. And in particular, there's variable expertise. We always see these wonderful studies from expert centers that look pretty good, but when you apply it in practice where most endoscopy takes place, those results are difficult to replicate in a way that is clinically important. I think the most important change we've seen in my career in the field of endoscopic imaging is the advancement of computer vision and AI technologies, which is rapidly replacing and often complementing most traditional imaging tools. So if we go back to the 1990s, when we really first started thinking about doing supplemental imaging, it really began with chromoendoscopy in the 1990s. Professor Guido was really the pioneer in this field, developed the Guido classification based on chromoendoscopy, the application of dye sprays. In the 2000s, we got high definition scopes, and this was later, or in some cases concurrently, offered with enhanced imaging such as narrowband imaging, early forms of Fujinon imaging, and confocal also allowed us to see with extremely high magnification and resolution. This also came with its own set of classifiers. They were named sometimes after the people who developed them, such as Sano, and then later went on to, for example, narrowband imaging classification systems, the Japanese narrowband imaging expert team, or JNet, Miami classification for confocal. And in each case, we had an expert or team of experts develop lesion detection and classifiers that worked well or reasonably well in expert hands. It was fundamentally challenging to apply these broadly. In the last decade, we've seen second generation imaging systems from narrowband imaging, iScan, blue laser and blue light imaging, endomicroscopy and volumetric laser endomicroscopy systems, all of which have expanded, but generally in this same theme of higher resolution, higher contrast that began with the chromoendoscopy. What's really changed now is AI. And AI takes a very fundamentally different approach to imaging. It does not rely on the endoscopist to perform the task in real time. It does rely on expert endoscopists to train these systems. Although even there, we're starting to see with deep learning systems, these systems can train themselves without supervision and without image labeling. So I think AI, compared to really what we've seen over the last 30 years, is a fundamentally different and transformative technology related to advanced endoscopic imaging. I'll just show a couple of examples. We went through several generations of narrowband imaging systems, beginning with the 180 series. It was a bit dark. It got a little brighter with the 190 series, and now we're onto the X1 Olympus platforms. Similarly, with other systems, we've seen FICE advance to blue light and blue laser imaging, and iScan advance. And we've seen multiple changes and improvements in all of these manufacturers' imaging system that basically make them higher contrast, higher resolution, and easier to use. We also need to think about that exposure issue. We've had multiple systems that increase our exposure because the image enhancement is only going to see what is on the screen. We have to expose the lesion. These involve human factors such as just simply good endoscopic technique, looking behind folds, washing the colon well, distending it well, mechanical issues, retroflexing in the right colon or the GE junction, for example, and optical factors such as wide angle endoscopes, all of which increase mucosal exposure independent of contrast and other optical features. So we've had multiple devices that have helped us see things better by exposing areas, for example, behind colon folds. These are two examples of cap-based systems. There's a very nice study I'll show in just a moment from Doug Rex looking at different cap systems. But fundamentally, we cannot get beyond the human factors. We will always have to pay attention to these issues because no imaging system is going to make us look behind a fold, at least not something we see in the near future. And these are issues we all know well: withdrawal time, mucosal watching, having your nurse or technician also watch the screen as you do a colonoscopy, and looking twice, especially in the right colon, and even retroflexing in the right colon are all issues that have been shown to improve our lesion detection. The classic application of this is adenoma detection. There's hundreds and hundreds of studies about different technologies looking at adenoma detection. I'm not going to review those today. I will show just a couple of recent examples, particularly with AI, on how we're seeing applications for adenoma detection. So this is the study I mentioned from Doug Rex. It's a nice 4-way randomized controlled trial of different ways to improve exposure. So it had a standard colonoscope, an endocuff assisted, an endo ring, and a wide angle scope called Fuse that just looked at a 330-degree field of view as opposed to the standard typically 170 degree field of view. And what he showed is that these cap-like devices, particularly in this case, the endocuff cap, significantly increased adenoma detection. So this tells us that it's not just how bright your imaging system is, how high contrast your imaging system is. You still need to expose those folds. You need to expose those polyps and get them on the screen. This was another application. Barrett's esophagus has been extremely well studied, particularly by the Amsterdam group led by Dr. Jacques Bergman, but also many others well known to the audience here. This was a meta-analysis actually 8 years ago now that our group did looking at what were multiple studies on chromoendoscopy and virtual chromoendoscopy, and they do work. They increase, in this case, Barrett's esophagus yield for dysplasia. So we know that these work. The issue is, can we make them work in everybody's hands, not just the expert hands? So the people that did these studies generally are all experts in Barrett's esophagus, but those are not the places where most people get their esophagus examined. So that's where AI has really been transformative. It does not depend, at least the detection and classification systems does not necessarily depend on the skill of the endoscopist. We know that AI is generally an intelligent behavior by machines rather than natural intelligence of humans. So basically, it's looking at an image, and in this case, in computer vision, it's looking at an image and saying, is there a relevant lesion on this image? And if so, what type of lesion is it? That's intelligent behavior that we as endoscopists do all the time. This is a classic example. This is the GI Genius system from Medtronic showing a flat polyp. This is the kind of polyp all of us miss. Even the best endoscopists in the world miss these types of lesions. I think AI is going to help all of us with finding these types of lesions. And fortunately, the science has moved very rapidly. This system is actually just recently approved by the US Food and Drug Administration, as well as CE marked, and also happy to say approved here in the United Arab Emirates where I live. This was a randomized control study led by Alessandro Repici and Cesare Hassan, looking at this system that I just showed. And as you can see, a very well done, very rigorous study, 350 patients randomized to each of a control arm and a CAD-E system. And the adenoma detection rate was dramatically increased from 40% in the control arm to 54, almost 55% with the CAD-E or AI enhanced colonoscopy. So it does work. It actually works across a broad range of polyp sizes, flat, non-polypoid, as well as proximal and distal. So these systems are robust. Recent meta-analyses of more than 6 randomized controlled trials show that really these work across all platforms. Really every randomized trial that's been published to date shows a positive benefit of these systems for adenoma detection. What about adenoma or polyp classification? They also seem to work very well here. This is actually an early study from Michael Byrne in Canada back in 2017, just looking at, can we classify polyps? In this case, using the NICE classification. And this is an AI system that he developed that allows a very accurate, you can see the ROC curves here, and ROC curves that approach that upper left corner of the box are very, very accurate. In this case, the area under the curve of the ROC curve was 0.95. That's roughly equivalent to a 95% overall accuracy. So the system seems to work very, very well. We've seen it now in Barrett's esophagus, and I'll just give you a short laundry list of applications. So this is a study in Barrett's esophagus, just recently published this last year in gastrointestinal endoscopy. And again, very similar results. We see very high levels of accuracy. And what's nice is that this does not depend on the endoscopist who's performing the exam. Obviously, they have to expose it, but once the Barrett's is appropriately exposed, the device, or software in this case, can tell you if there's a dysplastic lesion. Here it is in early squamous cell carcinoma of the esophagus. So we're seeing this very rapid expansion of applications. Again, what you can see here in the lower right corner, each of the small triangles represents experts. The curve here represents the AI system. So in this case, it's outperforming most experts. Another application, early gastric cancer. So across the upper GI tract and lower GI tract, we're seeing very similar overall high quality results. So just to summarize where we are right now with advanced imaging, I think advanced imaging plus AI are really maximizing lesion detection, and they allow, what I call an expert in a box. It's like having Doug Rex looking over your shoulder or Michael Kaminsky looking over your shoulder saying, there's a polyp there on the screen, you better pay attention to it. So I think these are going to allow a much more uniform application of lesion detection and classification systems. It does not, AI, advanced imaging, AI, artificial intelligence, does not replace the need for good mucosal exposures. There's still human factors that we as endoscopists need to pay attention to. You've got to get to the cecum, you've got to wash, you've got to distend, you've got to look behind folds. We're seeing a very rapid expansion in terms of the application. Polyp detection is now in clinical use with FDA and CE mark approval. This was very important because it established a so-called predicate device. Once the first device is approved, almost all subsequent devices can just show essential equivalence to that device and don't have to go through as rigorous a process. We're seeing it now develop as polyp classification systems, although there's some greater challenges there. But we're seeing it essentially in every other cancer dysplasia, from the esophagus, stomach, colitis-associated dysplasia. And we're starting to see it, as you saw in the earlier lectures, in EUS, ERCP, cholangioscopy, and particularly in radiology, there's been extensive applications. In fact, our group is working a lot in this area on early pancreas cancer detection. I want to thank you all for your time. This is a beautiful picture from the desert just inland from here that I took a couple of months ago of a couple of camels here. Thank you very much.
Thank you, Mike, for that fantastic overview on AI and endoscopic imaging. As a thought leader in this field, what do you see as the major obstacles standing in the way of AI gaining widespread utilization now?
Well, I think all of these systems are going to have to go through the same rigorous process that we saw for polyp detection to justify their use. So the regulatory bodies around the world, whether it's Europe, the United States, Asia, are all looking critically at, one, do they detect more lesions? Second, are they not making sure that we're not getting a lot of false positives where you might incorrectly act on a lesion, in particular, remove a lesion that is a benign, completely benign lesion. So I think we have to do the rigorous science to prove that these systems are safe and effective. But we have a model for that now. The first one being approved clearly gives us a pathway for the others to follow. I think the most important thing from a physician perspective is we need to let these tools make us better endoscopists. There is a potential that they could actually make us worse. If people start to get lazy and, for example, do a very rapid colon pullback, thinking the AI system's going to detect it for me, then the system hasn't improved the care of patients. So I think we need to use these tools to make us better physicians, not, I would say, lower quality physicians or just more efficient physicians.
I think a lot of the techniques you mentioned earlier, whether it's using NBI or EndoCuff or those additional tools, a lot of endoscopists don't like to spend the extra time to learn how to use those new technologies. So do you think that endoscopists will be more readily able to adopt the AI technology? Because in theory, it's less onus on them for pre-learning before a case.
Yeah, that's right, Uzma. One of the beauties of this is there really is no learning curve. You literally push the button, turn the machine on, and when you're doing a colonoscopy, you get a green box around a polyp. So there's not much more to learn than that. That's not completely true. Occasionally, you do get some false positives on bubbles or little bits of mucus. So you need to recognize what's a false positive. But what Cesare Hassan's done some very nice work in this area showing that those are really negligible. They don't introduce much time or alert fatigue. But there isn't a learning curve like we're used to with other systems.
And in Abu Dhabi, I don't know about how the costs work for everything, but in the US, in an endoscopy unit, cost is always a major issue in terms of adopting new technology.
That's right. So there's a number of studies actually that have looked at this, both from the physician, if your office or your practice is thinking about adding these technologies, they actually generally suggest that they're cost effective from at least the physician practice standpoint of view. If you find more polyps, at least in the US type reimbursement system, you get paid more for finding more polyps and removing more polyps, and there's more pathology charges. Now, if you're in a capitated system, like some parts of the world or even some parts of the United States, that is considered an expense. But generally speaking, if you increase your lesion detection, it's both cost effective from a pure financial standpoint of view to the practice, but more importantly, it's cost effective to the patient by preventing downstream costs of colorectal cancer care in the case of polyps.
All right, I think that's all the time we have right now. Thank you very much for that enlightening lecture and your thoughts on how this technology is going to be implemented in the future. Thank you.
Thank you. It's my pleasure to be here.
Michal, I think we lost Uzma. She had 2 espressos in the early morning, but I'll jump in for her and tell us which case you are showing us, and if she comes back, she will be your moderator again.
Thank you so much, Thomas and Uzma from the other side. Hello, everybody. Hello, world from Warsaw. We are really delighted to be joining you today from Warsaw, Poland. And I would like to start by introducing our team today. My name is Michael Kamiński. This is Marek Bugajski, who will be commenting together with me. We have a fabulous team, anesthesiology team, Thomas and Monia. And then we have Magda, also a endoscopy nurse, and Ola, who is responsible for a so-called ZIPPI trial, which we are doing together in international collaboration on Z-poem. And I will explain the details further on. So we will start by introducing the patient, and I will pass the word to Marek.
Okay, so just to start, we will be performing today a Z-poem procedure. So this is a treatment option for patients with Zenker's diverticulum, and as you already know, this is a patient with Zenker's diverticulum. This is a 66-year-old male, which is not that typical. He's a bit younger than usually are patients with Zenker's diverticulum. He has no significant comorbidities, so this is also not that usual as well. However, his Zenker's diverticulum is quite typical. So regarding the symptoms that led to this procedure today, we prefer to use so-called Kothari-Huber score And could you please show us the slide? This is a question for our technical team. Okay. And as you can see, the score, there are several scores that can be used for such patients to search for the implications for more aggressive treatment. But not all the scores take into account all the different factors that should be included because it's quite complex disease with different motility disorders included. The upper esophageal sphincter is not working properly. The relaxation is not working properly. And also the pressure in this region is increased. So this leads to many symptoms, not only the esophageal or digestive systems like dysphagia, as you can see on the slide, and weight loss that is due to dysphagia, but also there are some pharyngeal symptoms and respiratory syndromes, and also very important if the patients have increased risk of pneumonia. And all these factors, there are 7 factors as you can see on the slide, are included in the score, and patients can be assessed by it.
Okay, thank you so much. So we would like the procedure, the Z-poem on average takes 50 minutes. We have only 25 minutes, therefore we decided to show you how the Zenker looked before starting the treatment. So we have a very short video to show you, around 40 seconds. And this is, I would like to show you the first learning objective during this video. Can we have the video? Okay. So this is the examination from early morning, and we are now introducing the scope into the Zenker's diverticulum. This is a typical Zenker diverticulum, which is around, I would say, 35 millimeters in size. And it is quite useful to use a transparent cap to find esophageal lumen. And this is what we are trying to achieve right now. So you have to pull back the scope really a lot. And now the esophageal lumen appears on 12 o'clock. So it's tight. You can see that all the food probably goes into diverticulum because it's not so easy to go inside the esophagus, but then there is no real stricture. This is how it looks like. So we start with this video.
Yep. Do you always do Z-poem for your Zenker's diverticulotomies in your unit? Or do you vary treatment based on the size of the diverticulum or if they've had prior treatment?
Okay, so right now we are running a randomized trial which is called ZIPPY trial, comparing head-to-head flexible septotomy versus Zenker Z-poem. And in this trial, we have only symptomatic patients with a Zenker measuring between 2 and 5 centimeters in size, which is probably the best one and the most common one that fits our needs. You can also do Z-poem for recurrent disease, but it is slightly more difficult as there is a substantial fibrosis to be encountered during the Z-poem. Please remember that we have to do the third space endoscopy.
Also, it is important to note that there is some literature on efficacy of Z-poem and safety as well. However, ESG guidelines recommend proposing Z-poem to patients only in some form of experimental setting. So that's why we usually do it as a part of randomized trial or part of an observational study.
Yeah, the bottom line, so the potential benefit of Z-poem is that we can cut the septum and the entire cricopharyngeal muscle because we can see it, and we can even extend the myotomy along the muscle fibers of esophagus. Therefore, it is believed that it will result in less recurrence, which is relatively common after standard septotomy and accounts up to 30%, but let's say in meta-analysis it is around 15%. So it's still considerable percentage. And the other potential benefit of Z-poem is that we are not cutting the entire septum, but only the muscle part. And this may potentially prevent perforations, which happen quite often up to 5-6% during flexible septotomy. So we will move on to the procedure, and we started on, because the procedure takes on average 50 minutes, therefore we decided to start it and show you next steps. So you have seen the first part of the assessment. Right now you can see the diverticulum, and what you can see is the entry toward the septum. What we did an over the septum incision. There are two techniques. You can either try to enter the septum, to enter the submucosa in the proximal aspect or proximally to the septum. This is the first approach that was described. But I think that most of us are moving right now to the over the septum incision of the mucosa. So right now, what you see on the left side, we can see Zenker's diverticulum. On the right side, esophageal lumen, and right in the middle, we can see the mucosectomy and muscle fibers in the center. So we try to rotate and be gentle. We have to use a diagnostic scope, or it's much better to use diagnostic scope. We are currently using a Olympus scope with a X1 system, but this is a HQ190 system. So what you can see when we insufflate and rotate a little bit, we've already done the first part of the tunneling on the diverticular side. So what this is right now in the middle, the muscle septum, and what we really need to do is to enter the submucosa on esophageal side. So please have a look. I'm rotating the scope and I'm trying to enter it. If it's difficult, then I will use a injection to show where to go. So we need to inject a little bit in order to make some space and then to dig the tunnel on the esophageal side.
And regarding what cutting knife are you using for this procedure?
This is a Olympus dual knife, 1.5 millimeter. 2 millimeters. Yeah.
2 millimeters. So, okay. But I prefer, honestly speaking, I prefer you injecting through the needle, so open. Okay, please inject. Okay, so right now you can see that we are injecting, and this is the, okay, stop. We don't need so much. We can right now try to enter into the submucosa. Okay, can I have a knife already?
And what we use normal saline for injection, only with the blue color. But it's of course possible to use high viscosity fluid as well. This is just an operator preference for the type of fluid as well as for the type of knife, because there is no for now there is no evidence for any difference between different knives, and it's just based on the operator's choice. So as you can see here, Michał is starting to prepare the septum from the esophageal side. Of course, it is always the difficulty is to decide when to stop. When you do it from the side of the diverticulum, you can see on the outside when you take the scope out of the third space and move it to the diverticulum, you can see the line of where the blue color ends, and this is the place where your preparation ended. So this is the one way to be guided.
So you can also use, I mean, it depends on your preference, but we can inject a little bit more. There is very little injection right now, but it's not so necessary to have lots of injection, because we can see it relatively easily.
And of course, remember that we will be cutting through the septum. So any so-called mistakes are in fact not mistakes, because we will be cutting through the septum. The only part that we need to be really aware of and really careful is to not cut through the mucosa on the esophageal side, because this is the only true perforation for this procedure, very similar to standard POEM.
So right now we are, as you can see, yeah, Uzma, you have a question?
No, I was just going to say, for the audience, you're using a cap, always use CO2, obviously. And I was just going to ask if the patient was usually intubated for your diverticulotomies.
Yeah, the patients are always intubated for our diverticulotomies. I know that some people, especially with short septums, are not intubating their patients. I know that Alessandro is doing that, but we prefer, and we can even in our country afford it, to have this comfort to intubate patients. Can we inject a little bit more? So on the left side right now, just to explain, you can see the muscle fibers of the septum, and on the right side you'll see the submucosa on the esophageal side. Yeah, so right now we are trying to cut it and to go deeper and deeper in a way to have a long tunnel. Okay, thank you. We are using a little bit of adrenaline into our fluid just to prevent minor bleedings. But there is no proof that it really helps. It's just for the comfort of the operator to have a better or clearer view of the septum. Okay, open. Okay, inject. Okay, so right now it's probably a little bit more familiar to some of you. Okay, right now a little bit more. Okay, stop. Okay, so we have still these fibers in here. Okay, inject. Okay, stop. And the knife.
So at what point will you decide to stop the preparation from the esophageal side? Will you do checkup from the outside, or?
Yeah, I will try to enter the esophagus just to figure out where we are, how deep we are. And obviously this is not a big diverticulum. It looked a little bit bigger before intubation, which always happens. And even after the first mucosal incision, it seems to be a slightly smaller, and it's constant problem how to measure diverticulum, in fact, whether we should be using radiology or whether we should be using endoscopy, and how should we make it happen. And it's so it's debatable, but it's yeah, it's not a very big diverticulum, and it seems to be really in a good shape for can you switch off? Okay, I'm trying to rotate. It's not always so easy to navigate in this space. So we have to. We can also rotate the scope in order to change the position. Right now, the muscle layer is on the 6 o'clock position, and we are cutting along the
plane of the muscle.
Yeah. And we are not so much afraid of doing burning the mucosal, the muscle layer on the top of the fold. So right now, I think that we are already quite deep.
And also, as you can see, Michał is doing the cutting very close to the muscle, because it's due to the safety reasons. As I mentioned before, cutting through the mucosa of the esophagus is something that we really do not want. So it's better to keep very close to the muscle.
So right now, I think that you can see it really, really nicely. On the right side, there is a mucosa of the esophagus, which we cannot see. We are deeply into submucosa. And on the left side, you have the septum. And right now we have a really long tunnel on this side. And now we have a really well exposed, I hope that you can enjoy this view. We have really well exposed muscle bar in the middle. So right now we can start the dissection, and obviously there is different techniques. Some are using like scissor type knives, which are useful to cut this kind of a septum in the middle. But this is for let's say financial reasons. I'm using only one knife, honestly speaking, because it might be better to use different knives. So what you will see right now,
are you using for your cutting?
Right now,
the settings, can you show?
Okay, can we show the settings? Okay, so we are using Herbivire free, and for the tunneling, we were using the Swift coagulation 4.0, and for the mucosal incision as well as cutting through the muscle, we'll be using dry cut. These are the settings, which I like, which I'm used to for ESD procedures. Yeah. So the bottom line is to protect the mucosal surface, and I will just start cutting. You can see that the muscle bar right now is starting to bump. And at first, this first part will be really going relatively slowly. And later on, when the muscle layer will become a little bit thinner, then we will really see it much better. But right now, I'm trying to cut through. And what will happen, and what we are observing during the Z-poem, is that there will be two parts of the muscle. Right now in the middle, there starts to be like a division of the muscle. I will right now move to the esophageal side, and it's important if you have an unprotected knife to go into the other direction. So I change it, I change the position, I fully protect the mucosa, and then I proceed with the myotomy.
So do you always choose the right in the middle of the septum, or is it not important?
I think that it's I usually try to go right in the middle, but sometimes the septum is a little bit rotated, so you have to move around and find your own way. Okay, so right now we see a little bit better these parts of the muscle septum. We are cutting through step by step. You can see the muscles right in the middle. It's relatively thick, the muscle bar in this patient. But sometimes my experience is, I don't know, Uzma, what is yours? My experience is that with the smaller diverticula, the septum is usually thicker, but and with the larger diverticula, this becomes really thinner.
No,
so right now we are cutting. Yeah. Thank you.
You're almost making me a fan of Z-poem, because I do a traditional septotomy for my cases. But this looks beautiful, very nice exposure of the muscle. And again, as you pointed out, you'll be able to cut completely through and not worry about recurrence of symptoms from an incomplete dissection.
So right now you can see that we have some like submucosal space right in the middle. On the right side, we have muscle layer, and on the left side, there is still some muscle layer as well. We have some tiny bleeding happening. We'll see. Usually there is not so much of a bleeding in here, and the bleeding, if happens, usually comes from from mucosa, sometimes from the muscle layer. We'll try to.
I think we have less than 5 minutes to show this case, but you're moving along very nicely.
Thank you so much. Okay.
And as you can see, the bleeding is not that large, but it really makes it hard to find the cutting plane sometimes. we have Olympus X1 system that has this special viewing mode RDI that is sometimes helpful, but for now I think it's not that relevant in this case because the bleeding happens outside of the field of view for now, probably.
I think that bleeding...
Or maybe it's here, yeah.
It's somewhere here. We'll figure it out in a moment. Right now it's, yeah, it started bleeding. Okay. Let's move on. Let's try to see where it happens.
And you're just going to coagulate with the dual knife? Or you're going to use a coag grasper?
No, usually I'm coagulating with a dual knife. Usually it's, honestly speaking, it really rarely happens that we have some bleeding. Well, right now we can see the spot.
The spot, yeah. As you can see, it's very effective to just change from cutting to coagulation. The crucial part is to find the exact spot with the knife because you have a very small metal part at the end.
Okay, so here we come. Okay, we have. I hope that you can stay with us for just slightly longer to show you.
Because now happens what Michał has said before, that there are in fact two septums. One from the esophageal side that is part of the esophagus and we can cut through it. And the other one is more connected with the diverticulum itself, but we need to cut both of them up to the same height. And this is the main difference, and we think and we hope that we'll show it in the randomized trial. The main difference between ZPOM and traditional flexible septotomy is that ZPOM goes just until the end of the diverticulum, so we can cut just until the end. So the effectiveness is should be much better because in septotomy you would need to finish more or less at this point, I think.
Yeah, so right now what I would like to show you is that we are cutting. There is no muscle on the left side. I hope that you can see that. There is no muscle left on the diverticular side.
Yeah.
But there is still muscle on the esophageal side, and we can really nicely move on and cut the portion of the muscle layer on the esophageal side.
I think we'll have to go to the next case. But I was told to ask you if you can film the end of this procedure and perhaps show it a little bit later. But so far, fantastic demonstration of a Z-poem. Thank you.
Thank you so much.
Thank you very much.
Right now you can see
is a pioneer in diagnostic imaging. With over 70 years of expertise, we put cutting-edge tools in our customers' hands so patients get excellent results. Now we introduce Eluxio Ultra. Eluxio Ultra enhances your existing Eluxio platform by incorporating CAD-I, our powerful AI technology. With CAD-I, Eluxio Ultra is one of the first endoscopy solutions to detect and characterize lesions in real time, delivering our most powerful, complete, and comprehensive package for endoscopists. Eluxio Ultra will accommodate a range of future tools and technologies as they evolve, so our best endoscopy system for your patients today will remain so tomorrow. Human instinct plus artificial intelligence equals Eluxio Ultra, now available for your practice.
AI is going to change our life, also the life of endoscopists. AI has been introduced in endoscopy, especially in the colonoscopy field. I must congratulate to Fujifilm for being able to introduce into the market two different systems of AI for detection and characterization. They work very well. And this is going to be a great innovation for all of us. So using AI, we will have a sort of second operator guiding us, helping us, and whatever we're doing, whatever is the feeling that we have, if we are tired or we are at the end of the day or colonoscopy is being very complicated, we should not fear of missing polyps, which is a great problem with present colonoscopy, because AI will help us in looking to more polyps and also defining the histology, predicting the histology of these polyps.
For over 70 years, we have dedicated our efforts and energies to build a healthier world. We provide a powerful platform for endoscopy with cutting-edge solutions like CAD-eye AI technology. Now we have evolved from a trusted partner in equipment to an innovative leader in endoscopy, delivering solutions from screening to treatment. At Fujifilm, our goal is to become a one-stop solution provider by continuously striving for innovation. And now, we introduce our patient therapy portfolio with focus on tissue treatment. Our tissue treatment lineup consists of the cross snare, a hybrid snare to reduce the number of resection devices needed for polyps of different sizes. The ICUS 2, a precision injection needle for easy puncture and injection. The Resection Master, for optimal resection of flat lesions. The Octopus, a rotatable high-volume retrieval net. The hemostasis clip with its unique overlapping jaws and 90-degree distal hooks to close even large lesions. The Flush Knife BTS with excellent maneuverability, stability and injection capabilities for even smoother tissue dissection. The ST Hood, providing a clear view for a more efficient endoscopic treatment. Koala, a multi-tray polytrap for optimized tissue removal workflow. Our flagship tissue treatment lineup consists of the Manta, a high-performance needle with maximum injection flow rate and kink resistance, making injection of fluids easier. The Clutch Cutter, for all aspects of resection during ESD, from marking to coagulation, facilitating safety and efficiency. Purostat, a synthetic hemostatic material that creates a physical barrier to achieve hemostasis whilst maintaining clear visibility. The Cross Snare Zero, a dedicated cold snare with compacted wire technology for smooth and clean resections. Our unique compacted wire technology combines the benefits of a traditional snare with those of a braided snare for improved shape stability during cold snaring. Compacted wire technology enables a single snare to be used for a diverse range of resections and therefore increasing economic efficiency. With this lineup, we are strengthening our presence as a one-stop solution provider. At Fujifilm, we care about supporting the commitment and passion of healthcare professionals every day. Together, we can deliver high quality and reliable solutions to make people's lives better. We will never stop innovating for a healthier world. Fujifilm, value from innovation.
Again, thank you to our sponsors, Fujifilm this time. We move on. Among my favorite movies, there are two. One is called To Rome with Love, and the other one is The Russia House. So it's not surprising that we're moving to Rome to welcome one of our grand seigneurs of GI endoscopy and especially ERCP. And it's not surprising that the moderator will come from Russia, Evgeny Fedorov. Evgeny, can I hand you the moderation? I hand over the moderation to you. Welcome and thank you.
Sure, Thomas. Thank you very much for your kind introduction. And it's really great honor and privilege to be the armor bearer of the Night of Endoscopy. Anno Domini 2021, centenary of the Catholic University in Rome, where our faithful apostle is serving for many, many years, and forever fresh blessing, pancreatobiliary innovations. Together with the University of the Sacred Heart, we do hope a century of history ahead of us. So, dear colleagues, please welcome the ERCP Crusader our good old friend and colleague, Professor Guido Costamagna. Please, Guido.
Alessandro, for inviting me again in this fantastic trip of endoscopy on air. The topic that they gave me is innovations in video pancreatic endoscopy. These are my disclosures. And actually, 50 years have passed after the first descriptions by McCune in the United States and Itaro Oe in Japan of cannulation of the papilla to inject contrast and to do ERCP. And also 40 years have passed, unfortunately, since my first ERCP in Rome, after having been trained in Belgium by Michel Kramer. It was in March '82. Many things, of course, have changed during these decades, and it's impossible to speak about all of them. And so I decided to focus on 4 points very briefly: on cholangioscopy and pancreatoscopy, on single-use duodenoscopes, on the potential of 3D cholangiopancreatography, and some ideas on the application of AI in ERCP. Cholangioscopy and pancreatoscopy allow a direct visualization and inspections of the bile duct and pancreatic duct. And these techniques are there since many years, but have a new life with the single-use cholangioscopes. Single-use cholangioscopes allow to direct the biopsies, allow to apply instruments of virtual histology, and also to direct therapies like laser lithotripsy, electrohydraulic lithotripsy, or even laser tumor ablation. A couple of examples. This was a 58 years old female with a congenital liver cyst that developed painless jaundice. This was the MR before treatment. You see a very narrow part of the biliary tree at the hilum, and this is the drawing explaining the anatomy. It was not clear, the diagnosis, because of the presence of the cyst. So we did the cholangioscopy. You see here the insertion of the cystic duct, and then the common bile duct, here the hepatic duct, which becomes a little bit narrow, but still with the normal mucosa. But finally, reaching the hilum, some new vessels are seen, and this is some villosities, and this is very suggestive of neoplasia. And then we jump suddenly into the cyst, where we found some pearls of pure cholesterol stones within the cyst. So this was probably a congenital cyst of the intrahepatic duct that developed a malignancy at the insertion on the hepatic hilum. So finally, we were able to take biopsies in the suspected area here, and the final result was, in effect, a cholangiocarcinoma, hilar cholangiocarcinoma. Very difficult to diagnose without cholangioscopy. Another potential application is therapeutic. We know that lithotripsy of the bile duct may be done under direct vision, but also sometimes it can be used in the pancreatic duct. This was a small obstructing stone that was bypassed with a stent. And then we approached the stone with the pancreatoscopy. You see the typical appearance of a whitish pancreatic stone. And under direct vision, it's possible to do laser lithotripsy, or like in this case, electrohydraulic lithotripsy, which makes some artifacts on the image, as you can see. But it's very effective. Unfortunately, not all the pancreatic stones are easily reachable because of the presence of strictures. But in this case, it was very effective, and you will see that finally the stone was fragmented and extracted. This is something that Evgeny sent me a few days ago. We had a webinar with Russian colleagues, and the cholangiopancreatoscopy was presented. And as you can see from these voting results on more than 400 participants, the main indication is still today considered the examination and the targeted biopsy of undeterminate strictures of the bile and pancreatic ducts, but also lithotripsy after the lecture given by one of our colleagues was the second best indication for this technique. What about single-use duodenoscopes? As everybody knows, the Achilles heel of the duodenoscope is in the tip, the distal tip, where the complex mechanism of the elevator is placed, an area which is difficult to clean and which is also subjected to small trauma, and therefore the surface, the inner surface of the channel may become irregular and may host a biofilm. And as you know, in the last years, 32 documented duodenoscope-related outbreaks involving especially multi-drug resistant microorganisms, with over 400 patient infections and more than 20 deaths were reported. And this is only likely a part of the problem, because in smaller hospitals were never identified outbreaks. And the same FDA was unable to assess the frequency and the severity of the outbreaks. And finally, the microbiological surveillance is not a routine practice everywhere in the hospitals. So the idea was to avoid the reprocessing and to use a single-use duodenoscope. Actually, there are two models, one from Boston Scientific and which is FDA and CE approved, and the second one, which is only FDA approved. So we have clinical data only on the Exalt D duodenoscope, single-use duodenoscope. These were the first data published in 6 tertiary referral US centers by 7 expert endoscopists, 60 ERCP, and with a very, very high success, technical success. 96.7 were completed with this disposable duodenoscope, and only 3 patients had to be crossed over to a standard duodenoscope. Another study coming from 6 French centers published last year, again, 95% of successful completion of the exam and only 3 failures. These were probably more difficult than the study done in the United States, more difficult in terms of ASG grade. More than 50% were grade 2 and a third were grade 3. There were only 3 adverse events which were not related to the endoscopy. Finally, there is a randomized control trial which was performed in Orlando by the group of Rabos. Patients with low complexity procedures, AG grade 1 or 2, randomized into a single-use duodenoscope or reusable duodenoscope. As a matter of fact, the maneuverability was considered significantly worse for the single use in terms of ease, passage into the stomach, image quality, stability, and functionality of air-water button. However, if you look at the results in terms of technical success is even in favor of the single-use duodenoscope, and also the time taken for cannulation is significantly less with the single-use duodenoscope. That means that this scope may be used routinely. I will show you one example of our experience in this pandemic. We used this single-use duodenoscope in patients with MDRO and COVID-19 acute patient. This patient had both acute cholangitis with pus under pressure, as you can see. And you can also appreciate that the image is very good, that maneuverability allows all the maneuvers that are usually done with a reusable duodenoscope, in this case, a sphincterotomy with extraction of stones with a Dornier basket. And this is the X-ray and the stones extracted. So what do we need to know? We need to know which will be the indications to use this duodenoscope because of cost and because of disposal of the scopes. Of course, there is no impact of using this scope on endogenous infection caused by bacterial translocations. However, possible indications will be immunocompromised patients with hematologic cancer or severe neutropenia, patients that underwent transplantation that are immunosuppressed, liver, bone marrow, kidney, patients carriers of multiple drug-resistant organisms, and even probably some patients with under chemotherapy or radiotherapy for malignancies in the future. Again, this is very interesting to see, and courtesy of Evgeny Fyodorov. After my presentation to this webinar, most of the patients of the colleagues were convinced that, the majority at least, were convinced that this may be part of the future of pancreatobiliary endoscopy. Some words about 3D cholangiopancreatography. The idea comes from the concept of a hybrid platform, put together very high technology like ERCP, CT scan, the robotic arm angiographic ZIGO, and the 4D ultrasound that is already developed in Strasbourg, where I have the opportunity to go to work with. And this is something that can be very useful in special situations like this one, where there is a disconnected duct after surgery. And by obtaining a 3D cholangiography and rotating it, you can identify with very clear images the exact situation of the single branches, intrahepatic branches, and the collection. Other potential indications are, of course, the hilar tumors and where the interpretation of the anatomy may be difficult. We are very lucky. We just received this hybrid room in my unit at the Policlinico Gemelli with a CT scan, a gantry, and the new robotic arm Artis Pheno from Siemens that we were able to use a few times because we are still in the setting phase. And so we were able also to apply some new potential applications. You see here the 3D cholangiogram of a post-transplant patient who was already treated with some stents, and you can use the image projected on the screen without using X-ray to complete your procedure, in this case to place multiple plastic stents in the different intrahepatic branches to complete the treatment of the anastomotic stenosis by using only very, very low quantity of X-ray. And finally, a few words on the potential applications of AI in ERCP in the future. We all know that AI is able to do many things. It may drive cars, sales books, beats humans, makes money. And we all know that AI is already present very strongly in endoscopy thanks to colonoscopy. But what we foresee for the future is to try to use AI like and transform a hospital like an airport. So you see, this is the main difference between the hospital and neighbor. It's the tower that check everything. And the future, I think, will be that to have a black box in all the surgical rooms, but also in the endoscopy rooms, able to control what we do and to normalize the data. So in other words, the idea is that surgery and endoscopy should need aeronautics, where everything, all the information are available at the same time, in the same room, are combined together for the safety of the patients and the safety of the procedure. In other terms, we will go toward an augmented surgery and endoscopy, augmented eyes with virtual reality, augmented hands with robotics, and augmented brain with all the information that can be put together. Surgery and endoscopy recently has moved from being simple, sometimes ineffective, but relatively safe, to complex, effective, but potentially dangerous. That's why we need to implement the safety of our procedures. So interventional healthcare will evolve from an artisanal craft based on the individual experiences, preferences, and traditions of physicians into a discipline that relies on objective decision-making on the basis of layered, large-scale data from various sources available. And this will be true also for endoscopy. These are some experience already done and available in surgery. The so-called critical vision of safety to avoid lesions, intraoperative lesions of the bile duct, which are still a very important complication of the surgery. The artificial intelligence is able to recognize images and to make a guidance intraoperative to avoid the misidentification of the bile ducts. And the whole control of this procedure will avoid, for sure, severe complications like the injuries of the bile duct. These are some applications that are already available and published in the literature. What we are thinking to do is to try to use the same machine learning to, for instance, understand the difficulty of cannulation and the risk of potential complication during the ERCP. As you know, the papilla has many different phases that correspond to many different intramural shape of the common bile duct, which is the most difficult thing to overcome to get deep cannulation of the bile duct, the sigmoid intramural common bile duct. And therefore, collecting data and giving them to the machine most probably will improve our technical success also in ERCP. But this is only one of the potential application of AI in ERCP, because the best is certainly yes to come. Thank you very much for your attention.
Thank you very much, Guido, for your comprehensive and very impressive lecture. Unfortunately, only one short question to you, if possible. Would you think that all these new technologies will bring also the new procedures to pancreatobiliary endoscopy? For example, polypectomy from the gallbladder, or removal of the bile stones from the gallbladder directly via the papilla, or even dissection in the common bile duct. Would you think so in the future?
I think that we need only imagination, because the technical tools are still evolving every day. So I really think that there will be new procedures in the future, thanks also to the guidance and the keeping in mind that the safety of the patient is always the most important thing.
That's true. Once more, thank you so much. And as far as I understand, we are coming back to Warsaw.
Okay. Ciao, Evgeny.
Ciao. Ciao, Guido. Thank you.
Welcome back, guys. It's been a great morning, a lot of live cases, very beautiful. Congratulations to all the endoscopists who performed the cases. So happy to introduce this round table. I will have as a co-moderator, I have two co-moderators. So Pradeep Bhandari from Portsmouth, Cesare Hassan from Rome.
Hello.
I don't think they need any introduction. We have also other friends joining this round table. I don't know if they go live, all of them, but I think we have a bunch of experts. I can see Asmaa, Evelyn, Pratik, Cristiano, Michael Kaminsky, and somebody else. Also, Shuan should be there. So for all of you, thanks for joining this roundtable. The topic of the roundtable is innovation in colonoscopy. So I will start asking everybody what is the most important innovation in colonoscopy we have witnessed in the last 5 years. And I will start. I would like to start with Evelyn. Everybody has about 20 seconds and tell us what is the innovation that he or she loves more.
For me, the innovation, the greatest innovation is the resection of early cancers, because I think especially with screening programs and fit-based screening programs in place, we see more and more early cancers in our practice. And I think it's very good and a very new field for us that's clearly expanding at the moment, that we can remove those safely and efficaciously.
Cristiano?
If Cristiano is not talking to you.
Okay, if Cristiano is not there, so Pratik, welcome. It should be very heavy.
Hi, Ale, good to see you. And
it's very nice. You see these bodies I have.
Additional moderators along with you, just to run the small sessions. So,
I have bodyguard.
See all of you. So just following up on Evelyn and talking about resection, I think in the last, if you just say 5 years, I'd say that the increasing use of cold snare polypectomy. I'd say that, almost all of us have virtually transitioned to cold snaring of the diminutive and the small polyps, and now even extending them to larger serrated lesions. So just personally, I've seen that as a major change. The second would be, I think, just talking about bowel preps, for example. I think we've really seen a lot of bowel preps out there in the market that our patients can now use, right from regular volume to extremely low volume. And the split bowel prep now really gives us an excellent prep. So I'd say for me, at least, those are two major changes that I've seen over the last 5 years.
Thanks, Pradeep. Asmaa, welcome. So what about you?
Thank you. So I think artificial intelligence and computer-aided detection, which has, the technologies are already out and many on the way, but they've enabled us to see things that we weren't really cognizant of before, and also be able to size them. They tell us how well we retroflex, how well we examine all folds of the mucosa. So I think that's potentially going to really change the field and change all kinds of quality markers and training.
Oh, thank you. Mike? Mike Wallace.
Mike Wallace, okay. Well, since I'm going fifth here, I think that people have chosen the top 4 already. So it may not be the number 1.
That's difficult now. Now that's difficult.
Yeah. So for me, actually, underwater and water exchange colonoscopy has really made my life and my patients' lives much easier. We get to seek them more efficiently. It improves the bowel preparation. We know it improves adenoma detection, complemented by some of the underwater resection techniques. So the whole issue of sort of underwater colonoscopy, insertion, polyp resection, even large EMRs, we're doing some underwater. So I've adopted that quite widely into my practice now.
Okay, good. James, I see you. So
thank you.
What is innovative in Oxford?
I think it's not we're necessarily doing new things, but I think we're expanding indication. And for me, perhaps clipping has, particularly for hemostasis after large resection, I think the evidence base for that has become very strong. And we're really now using a lot of clips, and we can close larger defects. We saw in the little presentation just before this, the use of double-headed clips to get very wide, and even going with the over-the-scope clips. I think clipping has really kind of gone beyond just hemostasis for acute, for sort of single bleeding points, and now is very much more preventative for those big right-sided lesions.
So this is a great point. Xuan, don't tell me unsedated colonoscopy, please.
Goodness me. So all of the above, obviously. I think I'm going to go off piste a little bit and say our awareness of greener endoscopy across the whole GI tract. I think doing the right endoscopy on the right patient, not doing unnecessary endoscopy, trying to get it right first time so patients don't have to come back with lower recurrence rates. Everything through to whether or not we should be using disposable scopes, fewer accessories, recycling all of the materials that we use, and improving. I mean, this meeting is a perfect example of that. In days gone by, we would have all been flying around the world to see each other. But now we're able to do this in a much greener fashion. So even education in endoscopy can be greener and more sustainable.
Also, this is a very great point. Thank you for making this. So, Miguel, so congratulations for your Zenker. You did well, but not as good as a Milano, but it doesn't matter. Don't worry. Don't worry.
And Miguel, you know how much he likes you, right? Because you're the last one he's asking, so you have nothing to say.
No. There is Cristiano still. No, don't worry. There is Cristiano, Cesare, and Pradeep. There is
Cristiano has you on mute, Alessandro. He's not even listening.
Okay.
Well, Pradeep is busy texting on his phone.
I know.
Yeah, it's becoming...
This guy is not controllable. So, Miguel.
Yeah. So I think that over time it's becoming more and more difficult, and obviously we want to highlight something else which was not yet highlighted. And I think that there is, honestly speaking, two things which are really, I think, a major change. And one is less is more. So doing less, so some evidence, gaining evidence that doing less surveillance is more. That we are sometimes doing maybe too much, and we should go for a high quality, but let's say less frequent colonoscopy. This is one field which I would like to highlight. And the other thing is optimization of piecemeal EMR. I think that this was a revolution which happened over last, let's say, 5-6 years, with all the improvement like soft tip coagulation and so on. So there is many small improvements which really made our life much easier, and it results in better results for our patients.
Thanks, very good point. So I don't know if Cristiano is connected, he's unmuted now.
Yeah.
So Cristiano,
yeah,
I need to make a suggestion for you. Now it's the time of capsule, because nobody has mentioned the capsule colonoscopy. So probably you want to go in that direction, I don't know. So please tell us. I know you were prepared.
My intention
capsule, but so.
Well, I was not intended to talk about capsule, but well, actually, I don't think that capsule did a great improvement, at least capsule for colon capsule during the last few years. And we still have problems, and we are trying to solve problems, and problems are mainly related to prep. You know, Alessandro, that it's we are decreasing the volumes in colonoscopy. And in fact, I think this is one of the best achievements in colonoscopy. But unfortunately, in the field of capsule endoscopy, we couldn't, at least at the moment, reduce very much the volumes. And I think this still represents a great and important barrier for adoption.
So area for research. So now Cesare.
So Ale, what is new here is that nobody talked about advanced imaging. That is either blue light or this new bright chromo. It is true. Reset, discard, live in situ have not been incorporated in clinical practice. But this doesn't mean that everything was useless. If now we are preparing, as we heard, AI for characterization or for addressing resection, as Evelyn anticipated, is also because there was a lot of work in this year, first on the NICE, then on the WESP, then on the DNA. So don't underrate advanced imaging. I feel it will come back somewhat with AI.
I think it's so important in everyday practice. Now we use on a regular basis, and we guide our treatment based on that. So it's a great point. So Pradeep, you last.
Yeah, I'm always
so,
last.
Pradeep, your friend Pradeep Sharma allowed me to interview you. So you are approved by.
Thank you very much. It's a real pleasure. I think everybody has highlighted very relevant points. And myself, the main interest is imaging and resection. But a long time ago, I realized that I can't do good imaging. Doesn't matter the best endoscope in the world I have, or the best technique of ESD I have. I can't do the ESD if the bowel prep is not good. And I think we've made some major advances in bowel prep and improving the quality of bowel prep. The split prep was one major breakthrough which improved the quality of bowel prep. Now, since then, from 4-liter prep, we came down to 2-liter prep, and now to 1-liter bowel prep. We just recently did a study with our patients asking for acceptability, and 90% of the patients want to move to that. They're even happy. One of the problems we see, at least in UK, is that the morning patients who come for afternoon list have bowel prep as a split dose. The quality is very good. Whereas those patients who come in the morning, their bowel prep is not very good because they're taking everything the previous day. So we ask the patient, if you will be happy to take the bowel prep early in the morning, but nobody's interested in taking 2 and 4 liter, but they're very happy to accept a 1-liter bowel prep early in the morning.
So very good point. With regard to study, so Cesare, when you comment on the study that we recently completed, is online in GI endoscopy about the 1-liter bowel prep, and what was the results?
Yeah, so Ale, what is good of research is that the results are always the opposite of what you were expecting. Here we were comparing very small 1 liter, very big 4 liters. So maybe non-inferiority was acceptable, but at the end, the 1 liter came somewhat as a winner. You know why, Ale? Because by doing these trials, we learned here in Europe, and this is what we can broadcast worldwide, that there is a difference between an excellent level of bowel prep and adequate. This new low volume are shifting the bar toward the excellent. That is what you name as Boston 8-9. So Pradeep, to go back to what you were saying about detection and characterization, I feel that the excellent level is the new target of bowel prep. It's not anymore an adequate level of prep.
Evelyn,
So
can
Pradeep,
I
I have a question for you on the topic of bowel preps. What are your thoughts about the bowel prep, which allows you to clean an unclean colon at the time? You know, this new disruptive technology of being able to make an inadequate bowel prep adequate through aggressive washing. I don't know if you've heard about that system, but it seems to have a lot of appeal in certain healthcare systems like ours, where it's very hard to get patients back.
That's like a big water jet where you take your car through these jet washers, which instantly cleans your car. It's the same principle they've applied with a big overtube on your colonoscope and a big suction power as well. So I agree. It's a very important point because patients come for a big resection. We've allowed 3.5 hours of time for resection, and you find bowel prep is not good. So what do? It's a loss for everybody. So that's where it becomes really handy. But I don't think it's a solution for routine colonoscopy. I don't think we can use that in every single patient.
Yeah, also when you do this, it takes a lot of time. And also when you do screening colonoscopy, you want to see all the tiny mucosal abnormalities. If you use pressure with the water, the mucosa get hit somehow. So I'm not sure it's a final solution. I think it's much better going in the direction of small volume. So I would like to have a comment on this small volume 1 liter from Evelyn. Evelyn, you are the queen of colonoscopy, at least in Europe. And
I'm not so sure about that. It's an honor to be first again.
Okay.
Well, my worry is a little bit for the small volume that patients don't use extra other liquids. And what I do not like is the mucinous attached debris that's still inside that you have to wash really firmly to try to rinse off. So we don't use yet lower volume than the 2 liters pack now, and that's what is my worry. But it would be great for patients, of course, but I think we should be quite strict in asking them to drink extra water or other fluids than the prep, and that's where people sometimes leave out.
That's a very important point. We are doing a nationwide prospective observational study in about 100 different endoscopy units in Italy, and we were very straightforward with recommendation. Just after 1 liter split, just drink whatever you want, clear liquids. Two feelings. First one, endoscopists are super happy because all patients are very well prepared. And the other one, patients are super happy because they do enjoy to have additional liquids. They can have either tea or standard water or sparkling water or whatever. And I think this is a great step forward. So Shuan, you're using a small volume, big volume, what are you doing?
We're looking at it, and in selected cases, I think it is, it's really convenient in screening for same day procedures, afternoon and evening appointments, for example. So certainly our younger population prefer it because it's, it doesn't disrupt the day before. But as the point's already been made, it also needs to be in people who are willing to have a short, sharp result of the prep and who can drink a high volume. So for the more elderly and perhaps frailer patients who need a bit more time and, potentially better or slower preparation, I'm not sure it's going to be suitable for them. But certainly for the screening population or younger people who want to minimize the disruption to their procedures, because it is onerous. It's, it's a 2 or 3 day procedure, a colonoscopy. By the time you've added in the preparation, the day of the procedure, and some recovery rules about not driving and so on if they have sedation the following day. So to try and shorten it for those people is really important, I think. And our experience is, I can't tell the difference actually in the patients who've had the low volume same day prep. We're looking at it, and I'm blinded. I can't tell the difference. I haven't had too much problem with the sort of the mucus that Evelyn was talking about. Maybe our nurses drill down how important it is to drink the extra fluid. I don't know.
Thanks, Mike. You moved it to Abu Dhabi. What is the Middle East perspective?
The big issue here is that we're seeing very high rates of colorectal cancer in young patients. More than 40% of the colorectal cancers here occur under the age of 50. Fortunately, the government has approved screening beginning at age 40 for that reason, but we're seeing unusually high rates. It's not entirely clear why that is, if it's a dietary or obesity is also a parallel epidemic here. Unfortunately, there's not high uptake. We offer both FIT and primary colonoscopy, but uptake is still relatively modest. And we're also facing some gender-related issues. You may know we just recently published a paper in GIE from the United Arab Emirates on gender preferences, and we're understaffed with female endoscopists, and female patients strongly prefer female endoscopists. So that's part of the public health issue we're confronting, is making sure that we provide the care that patients are asking for, including gender-based preferences for endoscopists.
Thanks.
Can I say something? Sure. Mike, wherever you go, there is early onset. You were in US and there was early onset rectal cancer. Now you move to Abu Dhabi and there is early onset also in Abu Dhabi.
It's following me, I'm afraid. Maybe I'm the cause.
It's contaminated. Yeah.
So, Pratik, I have a question for you. So there has been a discussion in the past about safety of the lowest volume, but also we both discussed it several times over the phone. What is your feeling with the safety of this 1 liter bowel prep? Did you feel we are okay? Is there any issue? Pradeep.
Yeah, so that's a good point, Ali. I mean, and I think Evelyn did address it, indirectly. And, so what Alessandro is talking about is that at least in some of the initial studies, hypernatremia, or sodium shifts were associated with it, although not clinically significant. And I think part of those could be offset by the intake of free water, and one of the concerns with the small bowel prep in the past has been that will it cause these electrolyte shifts in a major way? And I don't think that the follow-up studies really confirmed that. But just along those lines, I think it's important when those patients are on that, they've been NPO for a while, and then you give them just this small volume bowel prep, is to make sure that the patients remain adequately hydrated. And if that's the use of water or juice or whatever it is that they can drink during the time period, I think that it will remain extremely important, to do that. So from a patient perspective, I think obviously they prefer it, just because, it's a smaller volume rather than the 4 liters that they have to take.
Yeah, I apologize to go somewhat against all of this mode, but in my view, this ultra low volume 1 liter, at least here in Europe, brought additional benefit in terms of excellent level of bowel prep without any compromise on safety, because here with Ali, we collected all the blood for sodium, chlorine, potassium. There was no shift. So the additional hydration was completely effective in addressing any issue on safety. But then we realized there is an additional benefit. And this is why, for instance, in our unit, we extensively use this low volume. It's not to make only patient happy, also to make ourselves as endoscopists happy. So I think that when this opportunity would be tried in all the country, probably you will get the same conclusion, that there is an additional benefit while there is no compromise on safety.
James, you have any comment on this?
I think certainly excellence is important. Obviously, in Oxford, we're very interested in inflammatory bowel disease. And so excellence to do that advanced imaging, be it virtual or dye-based chromoendoscopy, is critical. The other point that just as we were talking here that struck me is that patients with inflammatory bowel disease, particularly those with PSC or other higher risk indications, can be having colonoscopy every year in the lifetime of their disease. And so the prep can be quite psychologically difficult for them. And I think the importance of patient acceptability in patients where they have to have repeated colonoscopies, many colonoscopies in their lifetime, should not be underestimated. Some of our PSC patients, I think, have almost reached a stage where they're wanting very low volume preps, because with the higher volume preps, they get nauseated very rapidly. That may in fact be in part psychogenic. And so I think, again, a low volume prep that can give excellent results it is perhaps particularly good for patients who have to undergo a lot of colonoscopy in their lifetime.
Pradeep, what about you with these IBD patients?
Well, yeah, that's a very important point, because IBD is very challenging and you do need excellent bowel prep there. I was just going to say that I think we should not create confusion about low volume. Well, we need to talk about low volume, but ultimately patient has to drink a lot of fluid. So if somehow we need to get this message out very clearly that you only need to drink 1 liter of bowel prep solution, but you still are at liberty to drink a lot of pleasant fluid along with it. And that's where concern that Evelyn had about mucus, because the bowel is dry. And that's a concern I've heard from lots of other people. That concern can be addressed and alleviated because patients will be well hydrated, mucus issue will not be seen, and all these issues that Pratik and you were talking about, electrolyte disturbances, they will all be addressed. So I think our messaging needs to be a little bit better in terms of bowel prep, only 1 liter, but drink a lot of fluid. And then I think, I don't think there will be a debate.
Has my word about that?
In the pleasant fluid, we should instruct them not to drink any alcohol or beer, right?
That's for sure. That's for sure. Asmaa, you want to make any final point on this?
Yeah, absolutely. So, I think it depends also on the patient population. At my hospital, we serve mostly older and elderly individuals. And we actually have 2 or 3 different types of prep regimens, depending on who the patient is. So for some patients where we don't think they'll follow instructions with a lot of fluid intake, it's probably safer to go with the half lightly prep. And for patients that have had surgeries or gastric bypass, then certainly low volume is the preferred one. And then there's inpatients that actually need extended prep because they have spinal cord injury or other things. So we actually tailor our prep to the patient population. And, we use different strategies along with some enhanced nurse education, depending on who we're seeing. And yes, we had to write very clearly that clear liquids do not include any alcohol, because that question frequently came up.
Okay, so Cristiano, so I think there is another point to be addressed about patients with the previous surgery. So what is your experience on that?
Well, actually, you mean prep, Ale?
Yeah.
Yeah. Well, actually, we are shifting our prep in low volume, 1 liter, and we use in almost all patients, including patients with previous surgery, the 1 liter splitted on the same day regimen. And we are very happy with this. Also with patients with previous surgery, we are very happy with this.
Okay, Mikhail, you wrote a couple of landmark papers on the role of screening colonoscopy in prevention colorectal cancer and lowering the risk of death. So we have mentioned a lot of innovation. So this is bringing us to very low incidence of cancer in the future? Colorectal cancer?
Yeah, I think, thank you, Ali, for your question. I think that this will bring us to the very low incidence of post-colonoscopy cancer. For sure, I think that we have to think about it in 2 different dimensions. So the first dimension is normal screening colonoscopy, so no polyps identified. And if you fulfill the criteria for high quality colonoscopy, namely adequate bowel prep, cecum rich, and then ADR of certain thresholds, so high adenoma detection rates of performing endoscopies, then the risk of cancer for many, many years is really significantly reduced. And then there is another pool of patients, which is patients with polyps, and we are learning more and more about this population, because probably we have to better risk stratify. Some of them will still have a considerable risk of cancer after colonoscopy with polypectomy, with resection, and the other ones are at really low risk. And we always consider these patients as high-risk patients. But I think that, let's say, after removal of low-risk adenomas, the risk is really, really low. So with high adenoma detection rates, good quality, I believe that post-colonoscopy colorectal cancer will really maybe not disappear, because we won't zero the risk, but it will be very, very low. And at certain threshold, we have to say we can do more.
That's great. So I think we are almost at the end, and I want to thank you for being part of this roundtable, but also I want to thank you for how much you're doing with your research, your efforts in promoting quality colonoscopy, excellence in colonoscopy. Before we move back to Thomas, I would like to have 2 final words from Cesare and Pradeep as well.
Thank you, Ali. I was going to say that somehow we need to make bowel prep, the subject of bowel prep, more appealing, more sexy, so that more research is done, patients pay more attention to it, because it is so important. And we've always known this is very important, but haven't done much. Even now, we see a lot of endoscopists doing colonoscopy, commenting, bowel prep not good, but they've not taken any action. Patients
No
still book
recommendation.
3 years, 5 years later for next colonoscopy. So although we're having all this discussion, and thank you for putting this spotlight on this subject, because I think it's very important that patients take it seriously and we take it seriously. And that's when I think things will really improve.
Very grateful for this comment. Cesare, you are the last.
Yeah, so Ale, what we do today, the colonoscopy we do today is completely different from the colonoscopy we were doing 20 years ago. It was hard to learn, but fortunately, it's not enough because now AI is here and AI will revolutionize again colonoscopy. So in 10 years, it's not only us as endoscopy, it is a cyber endoscopist telling you whether colonoscopy was complete.
Probably also for bowel prep.
Good, yeah. Detection, navigation, catheter. So it's still ahead the best improvement of colonoscopy.
So, okay, thank you all. It's been wonderful having all of you, especially the American guys who had to wake up a little bit earlier. So we keep continuing our journey around the globe. I think the next will be Brussels with Jacques Devier, but I leave this to Thomas. Thank you, guys. Thank you, everybody.
Thanks. Bye-bye.
Thank you.
Bye, guys.
Bye.
Yeah.
Invitation. Yeah.
So I would like to thank you, Ale and Thomas, for the kind invitation to elaborate my experience on the technology. I just want to follow all the comments from the international panelists about how do we improve endoscopic resection. This is a rectal polyp that we discuss on complex polyp MDT. And that polyp was initially thought to be removed using the piecemeal resection or even unblocked dissection based on the British guidelines to have a proper extension surveillance. Then endocopic vision to and made an attempt to use the snare. However, the snare, as you can see, was it tried to manipulate around the polyp and tried to engage the polyp at the base, but unfortunately, it was felt that that polyp was not fully engaged within the snare. So even that was a type 2A genetic classification benign polyp, as you can see, we wouldn't achieve an unblocked dissection. And as you can see, based on the meta-analysis between ESD and EMR, the unblocked dissection is much higher performing an endoscopic submucosal dissection. But with the aid of technology, I think that can be facilitated. So this is a novel device with a new design. Named the Speedboat Inject. It has got a novel electrocarotic property, so using a bipolar radio frequency to have a precision on cutting the mucosa, as you can see, and in a very controlled manner. This is where the Speedboat Inject trying to isolate a vessel and apply the novel microwave coagulation, which is a very high frequency, decreasing the depth of the penetration. As you can see, by trying to come into contact, then you can apply the microwave very safely and very efficiently without the need of a change of any instrument. This Speedboat Inject device, as you can see, it can rotate very fine, and is controlled by one of the skilled nurses trying to come into close contact and have an effect on the vessel or the submucosa. By placing the device on the muscle layer, there's an insulation hull which actually protects the underlying muscle layer, and that augments a very seamless dissection on the muscle layer without creating any carbonization, and try to create a very nice tunneling through underneath the polyp and followed by the bridge formation technique. So after that, we release the using the device the right and the left hand side, and when an active bleeding is been encountered, then the appropriate use of microwave for longer, about up to 10 seconds, because every second will add up 10 joules. That will give a very safe and efficient coagulation of the active bleeding site. Then following this microwave coagulation, then we can also re-inject by using the integrated needle just to complete the left isolation of the margins, and then to have a proximal to distal dissection by the reassurance of the insulated hull, which will obviously protect the muscle layer. When